And I have no video feed. All right, Jake's going to get us set up. Good morning. How is everybody? Good. All of this technology and me don't go together very well. Okay. We'll let him troubleshoot that. All right, over between last class and today, you had chapter 4. Any questions on chapter 4? Let me kind of explain this really quickly before I get your scores. As CNAs, you are what we consider basic healthcare workers. So you have to have a basic understanding of how the body works. We can't just, I don't know, we have to have, our patients expect us to have just a basic understanding of body systems. But remember that we're not planning care, we're not making decisions, we're not diagnosing, we're not doing any of that. We're basically just a 5th grade review of how the body works together. Does that make sense? That's what chapter 4 was giving you. It's information that you actually already know because you cover it in 5th grade. But it's been a little while since you've covered it. So chapter 4 kind of went over the basics. You are not going to be tested on which body system exchanges oxygen and carbon dioxide. That's not relevant to your scope of practice. So there's not going to be any test questions on body systems and things like that. However, what you could be tested on and what you do need to know is how body systems change with aging. So the effect of aging on body systems. Does that make sense? And that's really what, turn the ATEM completely off and back on. Then unplug it from the computer and then reload, please. It's probably because the TV updated. It's not pulling in the feed. So in just a few moments, once we get technology to cooperate, I am going to go through a review of all of those body systems with you in class, specifically to talk about the changes of aging with each body system, because that's really what we need to know as a CNA. Now, we already covered some of this when we talked about washing rules. Remember, we were talking about that layer of fat going away and how that's going to affect your patient's ability to perceive temperature. You guys remember that? Awesome. Hey, look, I'm here. So that's just one change of aging. As we age, we have a whole bunch of changes in every single body system. So the best way for me to explain this, describe this, is if I invented something. Let's say I invent this thing, right? And I want to have it produced. And I go look at a factory that's going to make this for me. And the first factory I look at is brand new, state-of-the-art, super high quality items, works 24 hours a day with no problems. And the second factory I go look at is 90 years old, broken down, the springs are missing, the gears are rusted, and only works occasionally and doesn't really give us high quality items. Which one would I want to get? Right? I want the factory that's going to give me the best quality. Okay, the one that's new. Make sense? Well, your brain is a memory making factory. That's one of the things it does. It makes memories. So when your factory is new, the quality of memories it makes is good quality. Those are memories that are going to stick around for a very long time because the factory that made those memories was a good functioning factory. Good. Now, that 90-year-old person has a 90-year-old memory making factory. The factory aged with that person. So the memories that 90-year-old brain is going to make aren't going to be good quality. In fact, they may not even make memories right now. The factory might be offline. This is why, as we age and we're dealing with older individuals, somebody has absolutely no idea that they just had lunch, even though they just walked back from the cafeteria. No idea that they just had lunch, but they can remember the shoes they wore to a piano recital when they were 12. And you're like, that makes no sense. How can you remember something from that far away, but you can't remember what happened just now? Well, it's because the brain that's trying to make that memory isn't working right now. So don't get mad at them. Okay. If they say, when's lunch? You say, well, you just had lunch. And they go, well, when's lunch? We're not going to yell at them for not remembering. I just told you, you just had lunch. How can you not remember that? What we're going to say is, you just had lunch. Dinner will be at 5. So there's the clock there. At 5, we'll have dinner. But we have to understand that by them asking when's lunch, they may not be telling us they're hungry. They may be associating with something else. So we kind of have to dig a little deeper and figure out what is it that they're really trying to get from us. Good? So just like the brain is a memory-making factory, it also controls a lot of other processes as well. And it's not the only body system. We have a lot of other body systems, and none of those are going to work like they did when you were younger. As you age, your whole body ages. And I see this a lot in middle-aged people, and it's kind of a running joke in my family. My mom will say something like, well, you know, I've got this, I can't eat pizza anymore. And I'll say, well, you're getting a little older. And she says, yeah, but I've never had a problem eating pizza. Well, your stomach has never been 72 years old either, right? We tend to forget as we age that every part of our body is aging as well. And we're going to have age-related changes. Good? Makes sense? So let's become a little bit more aware of those age-related changes so that we know how to help our patients more effectively. All right, so let me get your scores for chapter 4. Daisy? Thank you. Daisy, do you have 2 and 3 for me?
Yes. Well, chapter 2, 1 wrong, and 100% for chapter 3.
Perfect, thank you. Chile?
100%.
Thank you. Emily?
I got -4.
Okay, and do you have 2 and 3 for me?
Yeah, I got 3 wrong on chapter 3 and 2 wrong on chapter 3.
Thank you. Madison?
1 wrong.
Thank you. Michael?
I got a 95.
Thank you. Sydney? Natalie?
75.
Thank you. Natalie, do you have 1, 2, and 3?
Yeah, 1 is 80, 2 is 95, and 3 is 90.
Thank you. Adrian? Dakota?
I only have half of it.
That's fine. Cheyenne?
I got 1 wrong.
Thank you. Sierra?
100 for all 3.
Thank you. Yesed? Yaleen?
I got 2 wrong.
Thank you. And Uni? Uni's not here. All right. Those of you that missed some of the questions, do you have any questions on what you missed? Anything you need me to explain to you? No? All right. Let's go ahead and do our review. So there's 10 body systems. Now, those of you who are going on for higher level medical training, nurses, respiratory therapists, ultrasound techs, those types of things, you're going to have an entire year of anatomy and physiology because you have to go through anatomy, physiology 1 and 2 with labs. So what we're doing here in the next 20 minutes is surface level. Anatomy and physiology goes way, way, way deeper than what we're going to cover here. We're just looking at a brief overview of the body systems. So there's 10 major body systems. We kind of group them together. But the thing that most people don't really understand about this, I mean, we know that our lungs breathe. We know that our stomach digests. I mean, we know that our bladder holds urine. I mean, we know the basics here. That's not really what this is about. it's important to understand that even though the lungs breathe, if something is wrong with the lungs, it's going to affect other body systems. It's not just the lungs, because the lungs get oxygen that goes into the bloodstream that feeds every single organ in the body. So if something is wrong with the lungs, you're going to have problems in the muscles and in the brain and in other body systems, because those body systems aren't getting what they need from the other body systems. So even though they're 10 systems, they all work together. So to me, the best way for me to envision this, because I'm a very visual learner, is I look at a city. Okay, look at a city. So a city has lots of people. Those are the cells. And in order for the people to do well, there have to be roads, because if there's no roads, people can't get where they need to go. So there's roads, and those are your arteries and your veins. You also have mail delivery, right? And you have trash pickup. And that trash has to go somewhere. So it goes to a landfill. There has to be a landfill somewhere in the vicinity of the city. There has to be places to eat. There's a lot of things that have to be in place for a city to be a city. And that's really what your body is. It's a whole bunch of different collections of cells that do different jobs that make the whole city run together. Because what would happen if the trash wasn't being picked up? Yeah, so in a city, you're going to have trash in the streets. It's going to smell. There's going to be more rats. There's just going to be a lot of problems. In the body, if the trash isn't being picked up, it's going to build up. It's going to decay. You're not going to, it's same thing. It's any interruption in service is going to cause a widespread effect in other areas. And that's what happens in the body too. So we have to understand that all parts of the body work together to keep the body healthy. If anything is wrong in any one system, it's going to affect other systems. So if we understand that, and then we start looking at how the aging process affects the body, we can start to see that getting old, it's no fun, because we have problems in every single body system as we age. And all of those are going to affect other body systems. So when we're dealing with older people and we're helping them brush their teeth, and oh my gosh, they're so slow, we tend to get a little aggravated because we've got 10 patients to help them brush their teeth, and this is taking forever. It's just quicker for me to do it. But that mindset can actually impact our patients. So it's important that we understand the aging process, so that with a little understanding, we tend to have a little more patience. Make sense? Good. So let's take a look at these body systems. So the first one we're going to talk about is the nervous system. This is the master control panel. This controls basically everything in the body. It does age. Short-term memory impairment is pretty common. Can't remember where you put your keys or why you walked into a room. Some of you get that now. You walk into a room, you're like, why am I here? That gets worse as you age. We do that now because of inattention. About 10 years ago, they said that we had the attention span of a goldfish. And it's only got worse from there. We no longer have the attention span of a goldfish. We have the attention span now of something more like an amoeba. I mean, and I'll prove it to you. If I said, okay, we're going to take about a 30-second break, you guys can do anything you want to, what would you guys pick up? Your phone. 30 seconds. We're going to take a 30-second break, and every one of you would reach for your phone. You could not sit still and do nothing for 30 seconds. That's kind of scary. Do you know where creativity happens? Creativity happens when you're bored, when you're sitting with nothing else to do. That's when creativity, that's when you come up with the big ideas. If your brain is constantly being entertained, constantly being distracted, you're going to lose the ability to innovate. Boredom is important, but we don't like boredom, so we pick up our phones to be entertained. So this is probably going to affect the next generation. Innovation will be a thing of the past. We'll let AI do that. AI is going to tell us what we need. That's scary, guys. So we need to understand that I'm concerned as a clinician, as a healthcare provider, I'm concerned about the effect of this constant need for entertainment and amusement, not just on innovation, but also on cerebral development. So if we see short-term memory loss in the elderly now, what's going to happen to people in your generation that aren't used to using that brain? How much sooner is this degradation going to kick in? And I'm concerned about that. And I'm hoping that they do some studies on this, because these are people, 70s, 80s, they didn't have entertainment nonstop. Their brain had to work a lot. And we still get short-term memory loss. So what do you think is going to happen to a muscle you're not using? What happens to a muscle you don't use? It atrophies. So how much sooner are we going to see these age-related changes in your generation? I'm thinking so. Now, I don't have any way of proving that hypothesis, but I'm hoping somebody studies this, because that constant need for distraction, and that's what it is, that constant need for distraction may have a long-term health implication. So next time you go to pick up your phone because you're bored, think about that. And you might be able to help overcome some of this. Does that make sense? Good. And I'm just as guilty. I carry my phone around. I pick it up. I have a little block matching puzzle that I play all the time, because I just, it's a mental break for me. And I started thinking about that. Well, wait a minute. This may not be, this may not be the right way of handling this. And what am I going to be facing later on because of the choices I'm making now? Something to think about. So as our brain ages, it's not just short-term memory loss we're facing. All of our senses are going to be affected. So eyesight gets affected. You may not be able to see as clearly. Writing may be harder to see. We may need some glasses for magnification. Your hearing gets affected. Your hearing, I love the ears. The ears are just like engineering marvels. They really are. And unless you stop and think about how you hear, it really doesn't make, it doesn't impact. But hearing, these are waves, like sound waves, percussion waves that enter your eardrum and vibrate some hairs. That vibration of those waves, we hear words, sounds, but those are all just waves, pressure waves. That's all they are. And they vibrate the hairs in the ears, and then that goes into a big conch shell looking thing, and that vibrates a little bone, and that vibration is picked up by your brain and interpreted as words or sounds. That's crazy. That's crazy. We hear words, but that's not what your ear is actually processing. It's crazy. So when you understand that inside the ears, all these little itty bitty teeny tiny miniature things that have to work for us to hear, and with aging, those things aren't going to work all that well, we start to understand that your older patients may have trouble hearing because they're little tiny itty bitty hairs and bones that have to work right. and the right amount of fluid to conduct those sounds. So we end up with diminished eyesight, diminished hearing, and you may have to repeat yourself a couple times with your older individuals. Make sure you're facing them, because a lot of times as we age and these little changes start to happen, we compensate. So it used to be that Jake could be over here and he could talk to me and I would be able to hear him. But as I get older, I now will, he'll say something, I'll go, huh? Because if I'm not facing him, if I can't see his facial expression and kind of watch his lips, I may not pick up everything that he says. It's an age-related change. So when we're, and you being young, you won't even think about that. So when we're talking with older people, make sure you're facing them. Make sure the lighting is good so that they can hear what you're saying. Some of you guys are getting a little older. As you get a little older into your 30s and 40s, you'll find you have to turn the radio down to see better, to pay attention, to find the street sign. Now, isn't that crazy? How does the radio have anything to do with what you're trying to see? But it does, because it's all processed in the brain, and the brain kind of loses one of those little branches. So we have to turn the radio down to see better. It's funny, but it's all connected. Now, one of the other things you're going to see with older patients, aside from vision, bless you, vision limitations and hearing, you'll also get a diminish in the sense of taste. So things that used to taste good to them, now they really don't. So your patients will often change their diet a lot of times. Where what are some of your favorite foods? What burger? Okay. What else? Lasagna. Ooh, yum. Okay, sushi, chicken, just plain like boiled chicken or fried chicken. Okay. Notice all of those are very strong tasting foods. Not a single one of you said bland chicken and applesauce. Right? Those are very strong. Lasagna. Oh, I make lasagna. Yeah. Pizza. Even sushi is a very strong tasting food. If you go into a facility, you're not going to see a lot of those strong tasting foods. And that's because your patient's sense of taste is probably affected, and they just can't tolerate those strong tastes any longer. So this is going to affect how we eat. It's also going to affect how we digest, and we'll get to that in just a few minutes. But all of our senses are going to be affected here. But one of the big ones that we have to be aware of when we're working with older people is our sense of balance and coordination. That's going to be affected in a very big way. Now, that's going to rely on your nerves, but also your muscles, your bone density. A lot of things go into play when it comes to balance and coordination. Even your ears are involved in balance and coordination. So our older patients are going to be more at risk for what? Falling. Absolutely. So we have to understand how all of this is going to work together and take steps to make sure our patients are safe while we're caring for them. So fall prevention is a very big part of what we do. And we have to understand that all of this is going to be involved in fall prevention. Okay. If we don't eat well because of our sense of taste, so we don't eat well, our bones don't get the minerals they need to stay strong. And something interesting, when I went to nursing school, I had no idea about this. I did not know this. But do you know that your heart requires calcium to beat? So if you don't take in enough calcium, your heart requires that. If you don't take in enough calcium, your body has to go find calcium. Now, it can't go to the local store and just buy it off the shelf. Your body has to mine it. Do you know where you store calcium? Bones and teeth. So if your body needs calcium for the heart to beat and there's not enough in the bloodstream, your body will send out little miners with little hard hats and pickaxes and chip away at the bone to pull some calcium out or at your teeth so that the heart can beat. So if we have poor intake and poor calcium levels, and our body has mined the calcium from the bones, and we have coordination problems, when the patient falls, what's likely to happen? Broken bones, all because we don't taste the same. Isn't that crazy how all of that goes together? So we have to be aware of this so that we can keep our patients safe. Another body system is a cardiovascular system. This is a very important system. Your heart has to beat, and your heart will take precedence over every other body system. We will sacrifice the kidneys to keep our heart beating. We will sacrifice the bones to keep our heart beating, because if the heart doesn't beat, the rest of it doesn't matter. So this is a body system that it's a very simple body system, very simple, but it's one that really ranks pretty high in level of importance, and it will absolutely sacrifice other body systems without a second thought. So your cardiovascular system is made up of your heart and your blood vessels. It moves blood around. But this body system will also age. So your heart, that when you're young is super strong and beats and pushes out these waves of blood that we learned about last week, right? These waves of blood that go out. Your heart's very strong when you're young. As you age, that heart muscle gets weaker. And instead of squeezing and getting that real good wave of blood out, it kind of goes more like, So your muscles aren't getting as much blood. What do you think that's going to do to the muscles if they're not getting good blood flow? So they atrophy, they start to shrink in size, they break down, they're not as strong, they don't do the job as well. And that's because the heart and the blood vessels are weaker with age. If you want to prevent that, 15 minutes of cardio every day of your life. Every day of your life. Keep your heart strong. Don't start when you're 40. It's usually what we do. We totally ignore our body until we get to be like 40 or 50. And then it's like, oh, this body has to stay with me for the rest of my life. I better do something about it. If you start young, 15 minutes of cardio every day, that keeps your heart in tip-top shape. Okay. Then we have our respiratory system. Respiratory system is, its whole goal is just to pull oxygen out of the air and get rid of your excess carbon dioxide. Because the heart can't do its job, or I should say, the heart doesn't need to do its job if there's nothing in the bloodstream to push around. The heart's not going to beat just to push water around. It's got to have some oxygen in the bloodstream to deliver. Okay. So being able to breathe effectively is important. And a lot of people think the reason we breathe is to get oxygen. That's actually not why you breathe. It's actually not why you breathe. You breathe to expel carbon dioxide, because you can live longer without breathing in than you can without breathing out. Carbon dioxide builds up in the bloodstream, makes us acidotic, and that breaks down all of your body tissues, including your brain. So you breathe to expel carbon dioxide, and then you bring in oxygen to replace it. Pretty cool. That's a problem, though, for people with COPD, because with COPD, they don't exhale that carbon dioxide very well. It's trapped inside. It's not able to get out of the body. So that carbon dioxide builds up, and now there's no room for oxygen. And your COPD patients will tell you, I feel like I can't breathe. help them sit up. Sitting up helps patients breathe more effectively. Endocrine system. Endocrine system is your hormone system. We know about hormone changes and aging, but this goes way beyond the traditional sex hormones. Your body relies on hormones all over the body, like thyroid hormones, pituitary hormones, adrenal hormones. There are hormones all over your body that regulate all these processes. They're like messengers. Those all start to diminish with aging. So your thyroid might not work as well. Your metabolism is going to be affected with that. You might feel cold when everybody else is warm. We've seen that with older people. But all of your endocrine systems will be affected, including insulin. Insulin is a hormone. And insulin, we're going to talk about a little later today, insulin is responsible for allowing glucose to enter the cells. Glucose is fuel. We tend to think of glucose as something bad. It's not, it's fuel. You wouldn't get too far in your car if you didn't fuel it up. Glucose is fuel. Your cells need that fuel, but the fuel needs to get into the cells. And that's what insulin does. Well, if our pancreas is old and not working well, our cells aren't going to get the fuel it needs. So the cells aren't going to be able to function well. Starting to see how old age is just no fun. Nothing is going to work right. Urinary system, kidneys, bladder, excreting excess fluid, excess electrolytes, that type of thing. Your urinary system is affected in a very big way with aging. Kidneys don't work right. And the urine it does produce, when it gets into the bladder is a muscle that gets floppy with age, so it may not hold on to the urine as well as it used to. So we end up with things like urgency, like, oh my gosh, I can't walk into a single store without having to visit their bathroom. Frequency. With men, sometimes it's unable to start and stop the stream of urine easily. With women, we get stress incontinence, which is the little muscle at the base of the bladder just gets floppy and isn't able to hold stuff as well. So your urinary system is affected. Well, let me go back here real quick. Incomplete emptying, that's a big one with older people. When you're working with older people, a lot of times we have everybody on a toileting schedule. So you take them to the toilet as soon as they get up in the morning. You take them to the toilet before every meal and after every meal, and then every 2 hours in between. So that it's very, very common to have older individuals on a toileting schedule. And that's because we know that they're not going to empty their bladder completely each time they go. So where you, as a young person, might go to the bathroom before your shift and then hold it all shift because you're so busy, your patients can't do that. And this can get very frustrating because a patient will hit the call light and say, I got to pee. And you're like, I just took you like 30 minutes ago. What? I'm able to hold it like 10 hours. You know, why can't you hold it 20 minutes? It's because of this. Integumentary, we've talked a little bit about this already. We get thinner skin. We get less fat deposit under the skin. So temperature regulation can be affected here. The skin gets thinner and drier and tears very easily. You get age spots and mysterious bruises that show up out of nowhere that we don't know where they came from. Changes in hair color, very common. Reproductive system, of course, is going to be affected. This is primarily driven by hormones, but also you get some physical changes along with the hormonal changes. So hot flashes and night sweats can become very common. Do you remember we learned how to make an occupied bed? You guys remember that? It's not uncommon, especially for older women, to have night sweats. So when they wake up in the morning, their bed, their sheets are wet. So if we have somebody that can't get out of bed for us to change the bed, don't leave them on wet sheets. We're going to change those sheets, get them on some dry sheets. Make sense? So hot flashes, very common. Now, hot flash or night sweats in young people is a cause of concern. We have to check that out. But night sweats in older individuals, pretty common. Gastrointestinal. This is going to be what most of your patients are going to complain about. Constipation is a real issue. Your older patients will be absolutely obsessed with their bowel routines. Obsessed. We want to try to help them as much as possible. So diet is going to play a part in this, but also activity, because those intestines that your food has to move through, those are smooth muscle. Now, smooth muscle doesn't contract on its own very well. It relies on external motion to move food through the intestinal system. So if your patient is sitting all day and they're not walking, they're not moving, they're not using those abs at all, that food is not going to move through their system very well. Not at all. And it's going to sit there and it's going to ferment and it gets hard and we get constipation. So this is why it's so important that we help patients do what they can do on their own. So if the patient can walk to the bathroom with assistance, don't bring a bedside commode over to them. We need them to walk to the bathroom. It's good for their muscles, it's good for their blood flow, and it's good for their digestion. The worst thing we ever did way back in the 60s and 70s is park old people in a bed, put side rails up and say, stay. Because they died within like 3 months of becoming bedbound. And it's because none of these systems work well without activity. So this is why we don't use side rails and we don't keep people in one position for a long period of time. We want them moving. Moving is important for all body systems. Musculoskeletal system, of course, your muscles get weaker, your bones can lose density. Activity is going to be super important for the musculoskeletal system. Super important. But inflammation of the joints leading to pain and stiffness, this is called arthritis, very common as we age because the lining of the joints wear down over time, another change of aging, and we end up with long-term effects of that. And that's what I've got going on in my knee right now. This is why I can't stand today. It hurts. I had no idea when I was young how much arthritis hurts. It hurts. So when your patients are like, no, I don't want to walk to the bathroom. Well, they don't want to walk because it hurts. But the problem is that if they don't get that activity in, that one joint is going to turn into 4. So it's really important to encourage our patients to be active as they can be. And this is why we do range of motion. Because if they can't do it, we're going to. Okay, good. We also have the lymphatic system. Your lymphatic system is responsible for keeping you healthy as far as protecting you from viruses and bacteria and excess fluid and things like that. Your lymph system isn't going to work all that well as you get older either. Those lymph nodes, they get clogged up. You know, a lifetime of fighting viruses, those lymph nodes get a little clogged up. So your patient is going to have a decreased immune system. They're going to catch everything you bring them. Everything. So during COVID, this became a real problem. During COVID, we shut down every long-term care facility. We didn't let family in. We didn't let visitors in. We let nobody in. The only people that could come in are the staff members. But the problem there is those same staff members that are in the facility caring for the patients, they leave that facility and they go to Publix. Or they go to, you know, whatever place they go. And they still gather in their homes, even though we weren't supposed to, with other people. So they are exposed to all of this stuff, all these viruses and all of these pathogens, and then they bring those into the facility to these patients who don't have a very good working immune system. So even though we closed down all of these facilities to the outside, we did not reduce their risk because healthcare workers were still being exposed and bringing that into the facility. So, right thought process, wrong implementation. Any questions on body systems? You need to know the changes of aging, what to expect in your patients. Okay. Old people are not like young people. They're like aliens. Nothing works the same. Nothing. So we have a pulse that we learned. We're going to do a brief review now. A pulse is a measurement of how many times the heart beat over 1 minute. Normal is 60 to 100. We're going to take the pulse, the radial pulse, at the top of the wrist. We're going to use 2 fingers, fingertips, not flat part, not your thumb. 2 fingers, find the pulse, put your thumb on the back and count for a full minute. Normal is between 60 and 100. We also learn how to dress a resident. We're going to remember USA first for this one. Undress strong arm first. They don't care what order you dress them in. If you want to put the shirt on first, that's fine. If you want to put the pants on first, that's fine. If you want to put the socks on first, that's fine. Nobody cares. But when it comes to the shirt, the order does matter. We're going to undress that strong arm first, make it do all the work. And then we're going to dress that weak arm first to make the strong arm do all the work after the weak side is dressed. Make sure your patient looks good at the end. All the buttons are fastened right. The pants are over the hips. The toe seams are across the toes. Make them look good. Okay. All dirty items go in the hamper. Nothing ever goes on the floor. And the call light goes in the stronger hand. We learned how to do hand and nail care as well. For hand and nail care, we soak the hand, we take it out, we wash it. We put it back in to rinse, we take it out to dry. Every time it's out of the basin, it should be on a towel. You're going to clean under the nails, wiping it off in between each nail. We're going to file in one direction toward the center, and then we put lotion on. We'll wipe off the excess lotion. Then clean up. It's a mini-mani. We learn how to make an occupied bed. So this is changing the sheets a half at a time. Never let the patient lay on a bare mattress. Clean rolls toward me, dirty rolls away. So we roll the dirty sheet under the patient. We roll the clean sheet toward us and tuck it under the dirty. Go around to the other side of the bed. Remove the old sheet, smooth out the new. Make sure it's connected at all 4 corners. Remove the wrinkles from under the patient. Keep them in the middle of the bed as we're doing this. Then put a top sheet on and a pillowcase. We learn how to do range of motion. Anytime we're doing range of motion, we lift from below. We support at the joints. Flexion, extension is up, down. Abduction, adduction is side to side. Rotation is around. So we exercise the joint that the care plan tells us to with the exercises that the care plan tells us to for the amount of repetitions that the care plan tells us to. That's it. Whew. It's a whole lot of stuff. Anybody lost? This is our halfway point. This is the halfway point of the class. Up until now, including today, you've had no practice time in class. Starting next week, you will have practice time. I will talk a little less next week. You will have some time at the end of class to practice. Monday is usually about 20 to 30 minutes. Wednesday is about 45 minutes. The following Monday, about an hour, hour and a half. And then graduation day, Wednesday, you'll have about 2 hours. So we have practice time built in starting next week. But if you don't know these principles, practice time isn't going to do you a bit of good. So how do we know what to do with each patient? Such a first step, always read your care plan. What does it say to do with this patient? Are all care plans going to be exactly the same? No. So once we know what to do and we want to start our skill, we're going to start with the opening. What's the first step of the opening? Knock. Sure. So, hi, Mr. Jones. My name is Patty. I'm your CNA today. I'm here to whatever. Is that okay? Close curtain. What do I want to do after I close that curtain? Wash my hands, and then I can go get my clean supplies. Well, if I need supplies, I need a place to put them. So what do I need to get first? A barrier. So I'm going to get a barrier and put it on the table. Which side should be facing up on the barrier? Yeah, the absorbent side. And then I'll go get the rest of my supplies. When I'm getting my supplies, can I hold them against my uniform? No, I have to hold them away from my uniform. While I'm getting supplies, I have to think about, do I need gloves? How do I know if I need gloves? Shouldn't I just wear them for everything all the time? No. How do I know if I need gloves? Okay, so if I'm going to be touching body fluids, personal skin, or non-intact skin, I need some gloves. What if it's, well, I'm not sure, maybe. Should I wear gloves if it's a maybe? Yes. So what if I know for sure I'm not going to touch any of those? Do I need gloves? No. All right. If I decide to wear gloves, what's the first thing they should touch? The patient. Absolutely. And then once they've touched the patient, are they clean or dirty? So I have to be careful about what else I touch in the environment with those dirty gloves. When it comes time to take them off, I have to remove them correctly. How do we remove gloves without contaminating ourselves? Okay, pinch up and then move under. Good. One of the supplies I might need to do a skill is a privacy blanket. How would I know if I need a privacy blanket? Okay, uncovered or undressed? Should I ever see knobby knees? Nope. Okay, and remember that privacy blankets are used to keep them warm and provide privacy. It's not just for privacy, it's also for temperature as well. When we put the blanket on, should we snap it? No, we're going to unfold it and then pull the sheet down underneath. At the end of the skill, when we're all done, do we take the privacy blanket off before or after we take our gloves off? After, because we don't want to touch that sheet with those dirty gloves. It's going to go right up next to our patient's face. Some other supplies we might need are linens. Washcloths and towels are very common. We do a lot of washing skills. So linens we might need. We might need linens for the bed as well. Linens. We have some rules to go with these linens. One of the rules is that we can't let our linens touch our uniform. We don't snap or shake them. Nothing goes on the floor ever. Not clean, not dirty, nothing on the floor. And we only get our linens after we've washed our hands. Remember that order matters. What if we take linens that we don't need? We discard them. Very good. So one of the questions I get asked a lot in the class is, how do I remember how many washcloths I need for all these skills? And there's an easy way to remember this for the test. If you're washing a small body part, like one hand or 1 foot, you need 2 washcloths. 1 to wash, 1 to rinse. Everything else takes 4. So hand care, foot care, 2 washcloths. Everything else takes 4. Good? All right. While we're doing bed skills, if the patient's going to remain in bed, where do they need to be in the bed? In the middle. If we have to turn them on their side, do they still need to be in the middle? Yes. So how do we turn somebody over but keep them in the middle of the bed? What do we need to do before we turn them? Right, scoot them toward us. So when we roll them, do we roll them toward us or away from us? Away from us. Okay. So we remain behind, the patient's behind. Sometimes we're going to do washing. So when we're getting our supplies, we need to get some washing items. So in this drawer, all of our washing items are in the middle drawer. So we need a basin, we need soap, and we need lotion for some skills. But when we get this, that is going to be really annoying today. When we get this, we're getting it with clean hands. So we get our basin and our soap and whatever else we need, and we put it on the table with clean hands. Now we have to go fill up our basin. So when we take this to the sink, can we touch the faucet? What do we need? A paper towel. So we're going to use a paper towel to turn the water on. How do I know it's the right temperature? Inside of my wrist. Is it enough for me to say it's a good temp? Who else has to check it? The patient. All right. If that water gets cold or soapy, because I'm taking a really long time to do this skill, should I address that? Okay. We're going to change that water if it gets cold or soapy. If we're going to use lotion anywhere, we warm it up in our hands. And then what do we do after we put the lotion on? Wipe off the excess. All right. So now that we've used our basin, we're going to clean it. And cleaning it is the same for every basin. We're going to rinse it, we're going to dry it, and we're going to store it. That's it. Rinse it, dry it, store it. But the process allows for disinfection. Remember, you can't be holding something while you disinfect it. Your gloves or hands are not clean. So when we put it away with a paper towel. So we're not touching these areas with our unclean hands. Good? And then every skill ends the same way. Thank you very much. I always thank them. They're the reason I have a job. They're the reason I get a paycheck. So thank you very much, Ms. Jones. Is there anything else I can get for you while I'm here? Let me explain to you why that statement is so important. You guys remember everything we just learned with the whole changes of aging and all that, right? All right. So if I don't take the time to take care of all the needs the patient has, in about 10 minutes, they're going to hit that call light. Because they're going to be laying there with nothing else to think about. And oh my gosh, I'm cold. I'm really cold. I'm freezing. I can't handle this. And I know they're super busy, but I have to have a blanket. I'm too cold. I can't lay here shivering. So they're going to hit the call light, and you're going to have to stop what you're doing with another patient and come in. And the patient's going to say, I'm cold. I'd like a blanket. And you're going to go get them a blanket, come back. If you're in a hurry and you don't ask, is there anything else I can get for you while I'm here? And you're rushing out the door and they don't say anything, they have to pee. Remember, their bladder isn't going to hold a whole lot. They got to pee. So they understand you're busy. They don't say anything. They don't stop you when you try to leave, and you leave, you go down the hallway, you're working with another patient, and 20 minutes later, that call light goes off. I'm so sorry to bother you, but I've got to pee and I can't hold it. So you have to get them out of bed, to the bathroom, get them back in bed, get them settled. You don't ask because you're busy. You run out the door, go see another patient, and 20 minutes later, they're on the call light again because I'm thirsty. So you get them a drink of water, you rush out the door again, and they hit the call light again. If you had stopped skill number 1 and said, is there anything else I can get for you while I'm here? If you make them feel like they're a priority and you don't rush out the door, she will tell you everything she needs. Take care of it while you're there. And that keeps her off the call light. And it helps with your workflow. So it's important. They know you're busy. They get it. But you need to take care of their needs while you're there rather than interrupting. That also keeps you from getting irritated at them. There are CNAs who will hide patients' call lights. You will hear words like they're abusing the call light. There is no way for a call light to be abused. It is physically impossible to abuse the call light because the call light is there to summon help that they are paying for. They're paying for it. So if you just slow yourself down during the closing, you'll find that it helps your workflow long term. So thank you very much, Miss Jones. Is there anything else I can get for you while I'm here? I will usually suggest something. Do you need to go to the bathroom or need a blanket before I go? How's your water? Did you take a drink? Once I get them all settled, can I get you a magazine before I go? Remember, we have that short attention span. Here's your call light. If you need anything, let me know. Environment is clean. That's a clue to me to make sure there's no barrier on my table. There's nothing on the floor. Everything looks good. Sheets are over the patient appropriately. Take a step back, look at the big picture. Environment's clean, bed's in low position. Open the curtain, go wash my hands. Remember, our checkpoint is end skill with clean hands. If I document after I wash my hands, what do I have to do? Wash them again. If I come back to the patient for any reason to give them a call light or water or anything, what do I have to do? Wash my hands again. End skill with clean hands. Good? Good. All right. Okay, so let's learn some new skills today. Page 138 is going to talk to us about side lying position. So if you look down the side, you can see all the principles that are involved in this skill. They're all spelled out for you there in the middle of the page. So this particular skill will have skill rules, follow the care plan, the opening, glove rules, barrier, privacy blanket, linen rules, scoot and roll, and the closing. We already know all of those steps. Nothing to learn there. What we want to focus on are the skill-specific steps for this skill. And you're going to see that in the black banner there. I have a video for it. Down at the bottom, you'll see the test-specific information. You should be able to change somebody's position in 8 minutes or less. You're turning them on their side, putting a couple pillows to keep them there. It's not an 8-minute skill. It's maybe a 4-minute skill, as long as you've done it once or twice. All right, step-by-step instructions are going to be located on page 139. Care plan is at the top of the page. Here is our care plan. Position the resident on his left side. Patient requires support and is unable to assist with turning. Does it say that they're immobile? Does it say that they're paralyzed? Does it say that they cannot move on their own? What does it say? They're unable to assist with turning. So imagine somebody who just had abdominal surgery. They're cut right down the middle. They can't flip on their side. Their muscles are not together. They need help flipping on their side, but they can still move. Don't put somebody in your brain that's different from the care plan person. Okay, so I could ask this person, can you scoot toward me? They can do that. They just can't roll. Good? Good. All right. So let's learn our skill-specific steps. Remember we talked about we can't use side rails without a doctor's order because they're a restraint. We talked about that in class. Half rails are fine. Positioning rails at the top of the bed, those are fine. But anything at the bottom of the bed that keeps our patient from getting out is a problem. So we can't rely on side rails when we're turning a patient. You're going to see this in a lot of videos on YouTube. A lot of videos out there put side rails up when they turn a patient, and they don't scoot the patient toward them. They just put the side rails up on the other side of the bed, turn the patient toward the side rail, and now the patient is right on the edge of the bed, pressed up against the side rail. Do you think that's comfortable for the patient? No, it's not. First of all, being pressed up against anything hard and metal, not comfortable at all. I mean, it's just that simple. But the second thing is, their brain is telling them, I'm too close to the edge of the bed. Their brain is telling them that, and they can't fix it. And that's going to cause them a lot of psychological distress. So side rails, even if you have them, should not be relied on for safety. Patients should be in the middle of the bed. not on the edge. I used to give that as homework, tell the students, go find a video on YouTube that positions a patient right up next to a side rail. And it doesn't take you long to do it. There's a lot of videos out there that do that, but think about the effect on the patient. Okay. So let's talk now about immobile patients. We already know this patient is not immobile. Doesn't tell us that they're paralyzed. It just says they can't roll. But a lot of students immediately bring to mind immobile. So let's talk a little bit about immobile, because somebody that can't move on their own is going to require a lot of care. If they can't move on their own, they can't do anything for themselves. Remember, everything you do takes movement. If you can't move, you can't do anything. That means we're doing mouth care. We're changing the position. We're changing the linens. We're getting them dressed. We're bathing them. Everything is going to have to be done to somebody who's immobile. But one of the specific things that we're going to have to do is change their position. You do this without even thinking about it. You do this automatically. And you do it all the time. Your body, every cell in your body requires oxygen and nutrients. Well, we have gravity on planet Earth. If we didn't have gravity, this would be a whole lot easier. But we have gravity, and gravity is always pulling things down. So right now, you are sitting in chairs, and gravity is pulling your body weight down through the seat of that chair. So my whole body weight is compressing that skin and tissue on my butt, because my butt is against the chair. So all of my body weight is pressing down on that tissue. That gets uncomfortable because those tissues get squished, and eventually they start yelling, I want some oxygen. I need some nutrients. I need some blood flow, please, because those blood vessels get compressed. No blood flow. Make sense? So what happens? You fidget. And all of you guys have been fidgeting as I've been talking. You change your leg, you start to swing, you shift, you lean, you're constantly in motion. And the reason for that, it's not that you're fidgety, it's that your muscles and other tissues need blood flow. So you've got to move the pressure off of one side and onto another so we can get blood flow to that area. You do this even when you're sleeping. You don't realize it, but you do. When you lay down and go to sleep, you don't wake up in exactly the same position. You're stretching and rolling and moving, and you're constantly in motion as you're sleeping. And it's because of this. This is why. Because your muscles start to get sore when you don't have good blood flow. So your body flips or stretches or moves in some way to relieve that compression and allow blood to get back to that area. You do this non-stop. But what would happen if you can't? If you can't move on your own, if we have compression of those tissues and those blood vessels, what would happen if we can't relieve that pressure? So we're going to do a little experiment here in this class together so that you can see how long this takes and what happens. So what I want you to do is sit on one of your hands. Just place one of your hands underneath your leg. You're going to leave it there for 2 minutes, and it's going to feel like the longest 2 minutes of your life because you're going to want to take that hand out. Please don't. Bear with me. 2 minutes. I'll tell you when to take it out. So we have different pressure points along our body. If we're laying down, the back of our head, the shoulders, the lower back or coccyx area, the back of the thighs, the back of the calves, the heels, anywhere where a bone is pressing down on muscle. If a bone is pressing down on muscle, fat, and skin, that is a pressure point. Remember, gravity is pulling everything down. Pressure point. Well, what happens is you have blood vessels in those tissues. And as all of that pressure is pressing down on those blood vessels, they compress, just like a straw. Straw is wide open, stuff can get through. But if I compress that straw, no blood coming through. So we end up with a decrease in blood flow to these areas. Now, we're going to further compound that by thinking about what that tissue is pressing down into. If we have a surface that has any ridges, grooves, crumbs, hearing aids, wrinkles, anything under it, that area of unevenness is going to press up into the tissues. So we have pressure from above, we have pressure from below, and what gets caught in between is not getting good blood flow. What do you think happens to tissue that doesn't get good blood flow? It dies. That is correct. So go ahead and pull your hand out real quick and take a look at it. Look closely. Do you have color changes? Do you have color changes? Look even closer. Can you see the pattern of the chair or your fabric that you're wearing on your hand? Can you see the pattern? That took 2 minutes. 2 minutes. And you already have color changes and imprinting. What do you think would happen if we left? Hello? Hey.
Body guys for a second. Can we move these guys? They're cutting concrete. I don't want anybody's cutting.
Yeah. Jake, can you move my car, please?
Thank you.
Thanks, Anthony. Anybody need to move your car? Anybody parked up front? Okay. This only took 2 minutes. What do you think would happen? How deep do you think those grooves would get if we left that hand there without moving it for 24 hours? What ends up happening? It doesn't take long. 2 minutes, you got changes. 2 minutes. After about 2 hours, whatever surface is cutting into your skin literally cuts the skin because of the pressure. It will separate the skin because we don't have good blood flow to the area. The tissues die and they lose integrity and they separate. We call these pressure sores. And it only takes about 2 hours to develop one. In patients that don't have good protein intake, no ability to move on their own, poor blood flow. So this can get really, really serious with your patients. And pressure sores are no joke. Pressure sores within a few hours can get deep enough that we see bone. And it can take months, if not years, to recover from. That's horrible. And the worst part is that it was 100% preventable. 100% preventable. Pressure sores are largely due to staff members not turning a patient or repositioning a patient that needs to be repositioned. Long-term care knows the risks here. So if we have somebody in a nursing home that can't move on their own, long-term care is pretty good about turning them because we don't want bed sores. Do you know the number one place where bed sores occur? Anybody know? Bless you. The hospital. Yep. Number one place for bed sores to occur is in the hospital. This is the one place that we absolutely positively should know better. What's that? Nursing homes get them, but not as often because the nursing home staff has been trained to turn your patients every 2 hours. We know this is a problem. So long-term care is better at compliance. Hospitals, they're so focused on the acute problem, what the patient is there for, the stroke or the heart attack or the broken hip, or that they forget about this and they don't turn the patients. So now your patient has a stroke or a heart attack or a broken hip and a bed sore. And remember, these things can take months, if not years, to heal. So we've got to get better about this. Those of you who are going to hospitals, understand that if nothing is on the care plan about turning a patient and they can't move on their own, You need to bring that to somebody's attention. Like, hey, bed sores, because it only takes 2 hours to develop one. You guys got changes in 2 minutes and you're healthy. Good? Make sense? So keep your eyes open. If you see something that isn't on the care plan that you know should be done, you need to bring it up.
So you said that it develops in 2 hours and they move them over 2 hours. Should they do it within 2 hours?
So it can develop in as soon as 2 hours.
So if it's longer than 2 hours, it's definitely.
Right, right. In a perfect world, it usually takes, as long as the patient's in relatively decent health, it usually will take a little bit longer than 2 hours, more like 6 or 8 before we start to see skin changes. But in somebody with a very low protein intake, protein is going to play a really big part in this. Somebody who is laying on wrinkles or the sheets are wet, that's going to speed this up. If we have other issues like poor oxygenation, COPD, or somebody who just had a heart attack and their heart isn't pumping well, so we have poor circulation. So it can occur in as little as 2 hours. Okay. Every situation is going to be a little bit different based on the needs of the patient. All right. So this is why you change position when you're sleeping. It's to help relieve this pressure. Well, if you can't change your position, you have to rely on somebody else to do it for you. It's that simple. So usually if we have somebody who can't change their position, either because of illness or injury, on the care plan, it's going to tell us to change their position every 2 hours around the clock. We're not letting them sleep through the night. We're changing their position every 2 hours. At 2 a.m., we're in there turning them over because the skin isn't going to take a nighttime break. It still needs oxygen. So every 2 hours around the clock. And the way we do this, we go from the back to the right side. And then 2 hours later, we're going to go back to the back. Because your back has fewer blood vessels and is less likely to react to the compression. So we go back, side, back to their back, 2 hours later, their left side, back to their back, 2 hours later, the right side, 2 hours later, back to their back, left, back, right, back, left, back. And we end up with something like this. This is called a turning clock. CNAs are allowed to make these and put them in the room. If there isn't a turning clock on the wall for somebody that needs to be turned, you can make these and put them in the room. So as the nurse, if I walked in, let's say, what time is it? 10:17, right? 10:17 a.m. If I looked at this clock at 10:17 a.m., the a.m. is on that side. At 10:17 a.m., where should the patient be? Can anybody see? At 10, just make it 10:20 a.m. So this is my 10, right? So between 10 and noon, right here, the patient should be positioned on their back. So I walk in the patient's room. I look at the clock. Patient should be on their back. I look at the patient. She's on her back. I'm good. My CNAs are doing what they're supposed to do. This is a quick way for everybody to check to make sure the patient is being cared for properly. The reason I like these is because it helps the families keep us accountable. Because a family can walk in the room at, let's say the family comes in at 2 o'clock in the afternoon. 2 o'clock in the afternoon. Okay. Let's say they come in a little before 2 and the patient's on their right side. At 2 o'clock, they know the patient needs to be back on their back. So if nobody comes in, and nobody comes in, and nobody comes in, that family member will go find a caregiver and say, hey, this patient needs to be repositioned. And that helps prevent pressure sores. Good. Sometimes we have to be held accountable as well because life gets busy. Questions? So you can make turning clocks as CNAs every 2 hours. Right back, left back, right back, left back, right back, left back. Never on your stomach, though. Notice not a single one of those has the patient on their stomach. And that's important. Unless the care plan specifically tells you to put an immobile patient on their stomach, please don't, because they may not have the muscle strength to pull their chest cavity off of their lungs. They have a lot of weight. When you put somebody on their stomach, all of that weight is on the lungs. And if the lungs can't inflate, we can suffocate the patient. This is why we never put babies on their stomach, side or back. Now, what was interesting is during COVID, there was a ICU nurse that put patients on their stomach in a prone position and actually found better oxygenation, that the alveoli were able to open up and oxygenate better. And that's because all the fluid that were in the lungs actually was pulled downward out of the air sacs of the lungs. So during COVID, we had patients on their stomach, but there was a very specific reason for it. So as CNAs, do we make that decision? What do we do? Follow the care plan. Good? Good. All right. So we remember that the patient always has to be in the middle of the bed. So if we're going to change their position, that means that we're going to scoot them toward us first and then roll them away from us, making sure they're in the center of the bed. They're not near the edge. So scoot them toward us and then roll them away from us so that they're in the middle of the bed after the turn. Now, if they can't scoot toward us, we can use a couple of processes to get them closer to us on the edge of the bed. You can move them in segments, like their head and shoulders, their hips, their legs, their feet. Just move them in segments towards you. That's fine. Or you can use a draw sheet. A draw sheet is a top sheet, just like this. But instead of being folded in half short ways, it's folded in half long ways. And it's put underneath the patient. We use it as a sling. So the top edge, the folded edge, goes under the shoulders. The other half, where the two sides come together, it goes under the legs, and you can actually just lift somebody up and scoot them towards you. Draw sheets are awesome. We've also got a different type of sheet that we use in some settings, but they're very expensive. They're called slide sheets, and they're very expensive, but it makes the patient almost levitate. They're pretty cool. They're like super slippery material. They're not wet, but they're super slippery, and it can actually help you move the patient on a surface without a lot of friction. But they're very expensive. So if you're using a slide sheet, if your care plan tells you to, you're probably going to have to go sign it out from your supervisor and then sign it back in when you return it, so it doesn't go missing. So go by your care plan how to move the patient. For the test, we just ask them, scoot toward me. Easy. Now, if our patient can't roll on their own, we have to position them properly before we roll them. If I just try to manhandle this woman and try to push her on her side in the position she's at, it's going to cause her and me a lot of stress. It's just not going to work out very well. I'm probably going to hurt one of us. So by helping position our patient properly before the turn, this becomes super easy. I can turn somebody 3 times my body weight with no stress on them or me. And I used to work with bariatric patients before they had weight loss surgery. This is 25 years ago, 30 years ago now. These are patients that are 600, 700, 800 pounds. They can't get out of bed. They're super debilitated because of the effects of all of that weight. And I would have to turn them. And I can easily turn somebody that is very, very large by myself by positioning them properly. The way we do this is the Remember, I'm always going to turn a patient away from me. Keep that in mind. We have to turn our patients away from us. So if this patient is going on her right side, facing that way, I'm going to be on this side of the bed because I'm turning her away from me. If I'm going to position this patient on her left side, I've got to be on that side of the bed to turn her away from me. Good. So let's say that I'm going to reposition this patient on her left side. So I would have to be on this side of the bed to reposition her on her left side. So I'm over here on this side of the bed. I'm going to scoot her toward me. So after the turn, she's in the middle. That furthest arm is going to go above her head. And the closest arm is going to cross her chest. Now, I can't do this on the mannequin because she doesn't bend. But furthest arm up, closest arm over. Closest knee bent at the knee. And the furthest leg is going to be angled out. But when I do that, when I have the patient scoot toward me and then I position them, they're already half on their side before I ever start to turn them. Okay. Proper positioning helps make the turn easy for them and you. But if I don't scoot her toward me, when I turn her, she's going to be too close to the edge of the bed. Even with a side rail there, it's too close. If I don't position her arms and legs before the turn, it's going to look very awkward. So let me show you what I mean. So if I scoot her toward me and I try to just turn her without positioning her arms and legs, I'm going to put my hand here and here, but it's very awkward. You see how she's sliding that direction? If you get your patient positioned properly first, so scoot toward me, one hand up, and remember, she doesn't really bend all that well. This arm crosses the chest. Well, it would. This knee is going to bend at the knee.
Sorry to bother you again. There's a blue key there. Is that any one of yours?
No. Oh, is it yours? Okay. Sorry.
That's all right. We just, like I said, we don't want them to get damaged.
Yeah, thanks. So this knee would be bent, and that knee is going to be angled out. So bent and angled. And then it's a very easy roll. So even though she doesn't bend all that well, you can see it's a whole lot easier. Okay, good. So proper preparation makes turning easier. All right. So we're going to follow our care plan. Remember, our care plan told us patient requires position the patient on his left side. He requires support to stay there. He's unable to assist with turning. We're going to do our opening. Knock, knock, knock. Hi, Mr. Jones. My name is Patty. I'm your CNA today. I'm here to change your position. Is that okay? Close curtain, wash hands, get my supplies. I'll decide if I need gloves. For the test, this is going to be done on a real person, one of you. How many of you guys plan on wearing clothes to go to the test? Okay. You are all completely clothed, holding on to all of your own body fluids when you're a patient for the test. So for the test, you're not going to need gloves. Now, if I were working on this lady and she's incontinent and in a hospital gown, would I need gloves? So it's not based on the skill, it's based on the patient. Good? All right. We're going to get our barrier, put it on the table, go get the rest of our supplies, which are 3 pillows and a privacy blanket. We're going to make sure the patient stays covered. I want to use a blanket for this and pull the sheet down just to be able to get to the legs a little bit easier, but you don't have to use a privacy blanket for this. You can just keep the sheet on. Just don't completely uncover the patient. No knobby knees. It's just really hard to get to their legs with a sheet in place. Don't let stuff touch your uniform. Keep the patient in the middle of the bed. We're going to position our patient properly before the turn. And then once we get them on their side, we're going to use a pillow behind the back to keep them there in a roll. We're going to put a pillow between the legs specifically between the knees and the ankles to keep them from pressing together. One leg they shouldn't be directly on top of each other. One should be slightly offset to the front. The top leg should be slightly offset. We're going to put a pillow under that top arm to get that shoulder in a neutral position. We're going to adjust the pillow underneath the head to make sure that it's supporting the head and neck and not scrunching that bottom shoulder up. Nope. Nope. Not yet. And then we're going to put the call light directly in the bottom hand, the one underneath the pillow, because we don't want that cord coming across the patient's neck. And then we'll do our closing. And that is the entire skill. Remember that this care plan is for this patient, nobody else. So your care plans out there may say something a little bit different. Let's go ahead and watch this video. And once this skill is over, we will take our break. Oh, nope, sorry. It's not playing. Oh. Do we have it on Fire TV? Good morning, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. Well, just change it to, for right now, Jake, just change it to the laptop, the output. Onto your left side and use some pillows to secure your position. Is that okay?
Yes.
Okay, I'm going to close the curtain, wash my hands, get my supplies, and I'll be right back.
Okay, hold on. I'm sorry. Put the audio to the laptop and play it anyway.
Mm-hmm.
Can't read it that well from here.
That one, yep. Try that one. You're not going to be able to hear it well. And take our break. That's annoying. Let's go ahead and take our break. And when we get back, I'll have that ready.
Get the light. Can I just try resetting the TV?
Yeah, that's fine.
Threw everything out of whack when we switched over to the OBS thing.
It's because Good morning, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. I need to turn you onto your left side and use some pillows to secure your position. Is that okay?
Yes.
Okay, I'm going to close the curtain, wash my hands, get my supplies, and I'll be right back. Now that I have clean hands, I'll get clean supplies. We're going to start with a barrier, and we'll place it on the overbed table. And this gives us a clean place to put our clean supplies. Now I'll get 3 pillows. And a privacy blanket. We'll bring this over to the side of the bed. Okay, Mr. Jones, I'm going to start with a privacy blanket. I'll place this on top of you to help protect your privacy and to keep you warm while we do this skill. So I'll take the privacy blanket and unfold it, being careful not to snap it or shake it. We'll lay it right over the patient on top of the sheet. Can you hold that for me? Thank you. I'm going to pull the sheet all the way down to the end of the bed. This just gets that sheet out of our way. Okay, Mr. Jones, can you scoot your body toward me? Thank you. Now I'm going to position you for the turn. So we're going to take the furthest arm and place it up over the head. The closest arm will cross the chest. The closest knee is going to bend with the foot flat on the bed. And then the furthest knee will angle out. Okay, just relax for me. Thank you. And now I'm going to roll you on your side on the count of 3. 1, 2, 3. So I'll roll the patient, maintaining a wide base of support. And then I'll use some pillows to keep him in this position. So the first pillow will go behind the back. We're going to move the privacy blanket out of our way so we don't tuck it in. The first pillow will go behind the back. We're going to tuck this edge underneath the patient. So I'm going to tuck down and under. This edge will roll up and then under the patient, down and under. And that provides a nice roll. We'll go to the other side of the bed. So this pillow will go between the legs, specifically between the knees and the ankles. We don't want the legs to lay right on top of each other, so I'm going to move the top leg just a little bit forward, and then I'll lift from below and place the pillow in between the legs. That way they're not laying right on top of each other, and the bony prominences are separated by the pillow. We'll cover the patient up. I'm going to take the third pillow, and this one will go underneath this top arm. As the arm droops down, this puts a lot of pressure along the upper back and into the neck. We need that arm in a neutral position. So I'll take the pillow, lift the arm from below, and place the pillow right under the elbow area of that top arm. Now the pillow under the head is under the bottom shoulder. So we're going to lift the head up, move the pillow so that it's only supporting the head and neck, and then we'll place that bottom arm underneath the pillow. We're going to take the call light and place it directly in that bottom hand. Okay, Mr. Jones, I'm going to remove the blanket and pull the sheet up now. So we'll pull the sheet right up over the blanket and the pillows, and then remove that privacy blanket, rolling it into a ball as we remove it so that trailing edges don't contaminate other surfaces. We'll adjust the sheet for neatness and appearance. And we'll open the privacy curtain. Mr. Jones, are you comfortable?
Yes.
Okay, I'm going to go dispose of my linens and I'll be right back. This will go into dirty linen. We'll dispose of the barrier in the trash can. And we'll move the tray table back to storage. Okay, Mr. Jones, is there anything else I can get for you while I'm here?
No, thank you.
Are you comfortable?
Yes.
Okay. Is the head of the bed, does it need to be adjusted at all?
No, thank you.
Your environment is clean. Bed is in the low position. I'm going to go wash my hands. After washing my hands, I'll review the care plan, make any corrections, and tell the evaluator my skill is done. Okay. Yeah, what does the care plan say? I can't answer that question for everybody because it depends on the care plan, right? Some patients, yeah, we're still going to reposition them every 2 hours. Other patients that are less at risk, the air pressure mattress will be able to accomplish the same thing. So it depends on the care plan. Easy answer. Do you see how easy it is, though, for us to slip into that decision-making mode? It doesn't take much effort at all. We try to solve the problem. Remember that the answer is the care plan to everything. Easy answer. Good? Any questions on sideline physician? That is one of my favorite skills. If I, at the test, if I got that one, I would be super happy. It's not a hard skill. It's not a long skill. The pillow behind the back will probably give you a little bit of problems when you first start doing it. So I would practice this on somebody at home. I have actually done this on my dog. Yeah. Yeah. After he had surgery, I actually moved him into a different position and used a pillow. I've done this on my dog to relieve pressure. So yeah, I mean, you can do this on live people at home. If you don't have a live person, get creative. Use a rolled up sleeping bag, or, you know, put something in the bed and try to tuck a pillow under it. Okay, good. Let's move on. Foot care. This is going to be on page 118 of your book. Okay. Do you guys remember hand and nail care? Foot care is just like hand and nail care, a little lower, but we don't do anything with toenails. We're not going to clean under them, and we're not going to file them. So what's left? Well, we soak the hand, wash the hand, rinse the hand, and dried the hand, and put lotion on it. We're going to soak the foot, wash the foot, rinse the foot, dry the foot, and put lotion on it. That's foot care. So there's a couple of different reasons. Number one, we don't trim anything, fingernails or toenails. But toenails, as we age, tend to get thicker often are affected by fungus, a toenail fungus, because think about your feet, right? Your feet hardly ever see the light of day, right? They're in socks and shoes most of your waking hours. So warm, dark, moist tends to create fungus in the toenail. And you'll see that by the toenails getting thick and discolored yellow. Well, we don't want that. That's not something that CNAs deal with. So that has to be addressed by a podiatrist. Because of that thickening of the toenails and the yellowing of the toenails, they have to be trimmed and filed and sometimes ground down in a different way. So as CNAs, our responsibility is to look at the foot. If we notice that the foot needs any kind of attention, anything, we let the nurse know. The nurse puts the patient on a podiatry list. And then when the podiatrist comes in once a month, they see everybody on the list. So the only way for the patient to get seen by the podiatrist is for us to do foot care, recognize there's a problem, and report it. Okay. Screen.
Oh, I'm sorry.
No, you're good. You're good. Let me take this one first.
Is there anything that could be added to the washing plan for foot care? Like if you need to, I don't have an example.
Absolutely. Absolutely. So we're always going to follow that care plan. So believe it or not, there is a treatment that we use occasionally when somebody has the beginning stages of toenail fungus or athlete's foot. You may see on the care plan to add the old-fashioned original yellow Listerine to the water. Listerine, yep, for the feet to soak the foot in, yep. So there's also something called a Dakin solution, which is a really, really, really weak bleach solution that can be added to the water. We don't like saying bleach because patients get a little freaked out, so we call it a Dakin's solution. But there's, I've seen vinegar, I've seen tea tree oil. So there's different things that can be added, but do we make those decisions? We just follow the care plan. So yes, good question. But probably the most common one you'll see is the old-fashioned yellow Listerine. Yep. All right, Nikisha says, are you able to work from the care plan or you have to know all the steps? Oh, good question, Nikisha. So for the test, I'm going to specifically talk about the test right now. For the test, you're going to get a care plan. And that care plan is yours throughout the test. You can go back to it and read it as often as you need to. You can stop in the middle of the skill and go read the care plan. It's yours throughout the test, but the care plan isn't going to tell you the steps. You have to know the steps. The care plan will tell you what to do, but not how to do it. So that's what we're learning now are the steps or the how to. So take that down, Jake, please. So if you look at this page, you can see all of those principles. Remember, those principles are steps we're going to do. We're going to do the opening. We're going to use our glove rules. We're going to use a barrier. Those steps tell us what to do. And then the black banner are steps specific to this skill and only this skill. Okay. Somebody with your level of experience should be able to do this skill in 13 minutes or less. Guys, all we're doing is soaking a foot, washing a foot, rinsing a foot, drying a foot, lotioning a foot. They're giving you 13 minutes to do that. The worst part about this is it's on the floor. You've got to set up on the floor, right? So the barrier doesn't go on the table, it goes on the floor. We're going to put all of our supplies on the barrier, and then we have to get down on the floor and do this skill, and then we have to get off the floor. I have a hard time with that now. This is a hard one for me. But to me, that's the hardest part of the skill. Other than that, you're just soaking the foot, washing the foot, rinsing the foot, drying the foot, and lotioning the foot. But that's not why you're there. You're not actually there to clean the foot. You're there to look. That's the whole purpose of this. Because feet are covered by socks and shoes a lot of our waking hours. So a lot of times we won't even know that there's an issue with the foot, or the patient won't even know there's an issue with the foot. So we do foot care generally once a week on long-term care patients to look for issues that need to be solved by the podiatrist. That's why we're doing this. Betty, there is something I want to know. If you're doing dental care, are you supposed to do mouth care at the same time? I think you're talking about dentures, Betty. Yes, denture. We're going to get to dentures next week. But when we clean dentures, we clean the mouth those dentures came out of as well. So yes. Yes. Okay, so our our step-by-step instructions on page 119, supplies are at the bottom. Remember, we have to learn our supplies. And at the top is our care plan. Here's our care plan. Provide foot care to 1 foot. 1 foot. What if the patient has 2? We're only doing 1. Even though they have 2, we're only doing 1. The test is going to let you pick. They don't care. Because they figure if they watch you wash 1 foot, rinse 1 foot, dry 1 foot, lotion 1 foot, you can do it on the other side. We don't need to see that. Where those evaluators want to be? At home in their pools, drinking their margaritas. They do not want to be watching you wash feet. So as long as they see it on 1, that's all they need. That's why our care plan says 1. Okay. It tells us to wash the foot using soap and water. If it told us to add some Listerine, what would we do? Okay. We're going to do what the care plan tells us to do, no matter how weird it seems to us. The resident is sitting in a chair and their sock and shoe should be replaced at the end of the skill. So let me tell you why that last sentence is there. That last sentence is only there for the test. It's only there for the test. During the test, you will be a patient. This is a live patient skill. That means that somebody might be washing your foot during the test. Chances are you don't have an extra set of socks in your back pocket. You only have the shoes and socks you came in with. So there are no clean socks available to put on your clean foot. In a clinical setting, we have a clean foot that deserves a clean sock. But for the test, we don't have any clean socks. Make sense? Good? So for the test, we have a care plan that tells us to replace their sock and shoe at the end of the skill. Tells you what to do. Don't leave them sitting there with 1 shoe and sock on and a bare foot. That would be weird. Good? Questions? So that last sentence is just for the test. Tells you what to do. All right, so let's look at the skill-specific steps. We know everything else. We know to read the care plan. We know to do the opening. We know to use a barrier. We know that gloves are going to be required because there's a maybe here. There's a maybe. We might touch non-intact skin. We don't know. We won't know until we get in there and start looking. So because there's a maybe, we're going to use some gloves. Plus, it's feet. Linen rules, right? Don't let the linens touch a uniform. Use what you take. Nothing on the floor. We know our washing rules. We check the water. They check the water. It should feel warm. Don't put soap in the basin. Warm your lotion up before, wipe it off after. All those rules. Going to clean the basin the same way we clean everything else, and we're going to do our closing. We already know all those.
Okay, so if we're looking at their feet and we notice the skin is intact, would we take the gloves off and start cleaning, or clean the gloves?
No, you can leave the gloves. They're already on, so just leave them on. Yeah. You do want to wear gloves initially, though, and we're going to talk about this why in just a second, because we're going to talk a little bit about diabetes. So with diabetes, a lot of times your patients will have foot issues and not even know that they have foot issues. They have no idea that there's a wound or a sore or anything else. So because there's an unknown there, we definitely want to wear gloves. We're doing the inspecting. And the problem is that you guys are still young. You're bendy. You are bendy when you're young. You aren't so bendy when you get older. You could look at the bottom of your foot now. You can pull your foot up to your leg and you can look at the bottom of your foot. And you're looking at me like other people can't do that because you're young and you assume that everybody else is able to do what you can do. As you get older, you become less flexible, and older people have not seen the bottom of their own feet in years. So if they're not looking at the bottom of their feet, somebody should be. And that's what this skill is all about, is recognizing your patient doesn't have the same flexibility as you do. So we're going to be their eyes. Okay. Okay. So this is a whole lot like hand and nail care. We're going to soak the foot, just like we did with hand and nail care on the hand. We're going to rinse or wash the foot. We're going to rinse the foot. We're going to dry the foot, and we're going to lotion the foot. We are not doing anything with toenails here. First, we'll read that care plan. Then we'll do our opening. We'll get some gloves. We're going to put a barrier on the floor. We're going to get our supplies and put it on the barrier. Whatever we wash, we rinse. Whatever we rinse, we dry. Make sure your patient checks the water temperature. We'll clean the basin the same way we clean everything else. And now we're going to get to our skill-specific steps. So we need to soak the foot in the basin of water. Now, I just got a question yesterday on this video, on the foot care video. You don't soak for 5 minutes. The test does not have you soak for a specific amount of time. There's a lot of instructors out there telling people they have to soak for 5 minutes. We only have 13 minutes to do this skill. If you're standing there staring at somebody for 5 minutes while they're soaking their foot in a basin of water, can you imagine how awkward it is if this room stayed completely quiet for 5 minutes? Don't pick up your phone. We're going to stand here and stare at each other for 5 minutes. Ready, go. Now, that was only 10 seconds, and it's awkward. We're not doing that for the test. We're just putting the foot in the basin. Okay. In a clinical setting, you do want it to soak. No specific time. Get them soaking. Go take care of somebody else. Go take somebody to the bathroom, brush somebody's teeth, take somebody for a walk, whatever you got to do, and then come back and finish up foot care. Don't stare at somebody for 5 minutes. But for the test, you have no other patients. So we're just going to put the foot in the basin. Don't have to soak for a specific amount of time. We're going to lift. Anytime we lift the foot out of the basin, we're going to support it at the back of the leg and the sole of the foot. Make sure you're supporting that foot as we move it. We're going to wash, rinse, and dry the foot. Those are your checkpoints right there. Wash top and bottom of foot in between toes. Remove soap from foot, including between toes. And dry top and bottom of foot, including between toes. Those are your checkpoints. There's nothing specific here. There's nothing difficult. You're just washing the foot. But that's not why you're there. You're there to look. Okay. We're going to put lotion everywhere except between the toes. No lotion between the toes. Lotion holds in moisture. Remember, your toes in between are going to be warm, body heat, skin folds. So no lotion between the toes. Everywhere else is good, but not between the toes. We don't want them to get athlete's foot. And you want to look for anything, red areas, scratches, wounds, abrasions, anything that you see, toenails that need to be dealt with. Anything you see that looks unusual, make sure you report. Don't put your patient's barefoot directly on the floor. That's what the barrier is for. Remember, nothing on the floor. And then when we put the sock back on, smooth it out so there's no wrinkles before you put the shoe back on. And then put their shoe on. Do your closing. This is not a hard skill at all. Remember that this skill is just for this patient. That's it. That's it. So let me talk to you really quickly about, oh, okay. I see what I did there. Okay. I'm going to talk to you really quickly about diabetes before I show you this particular video. And then we're going to get to mouth care. And the last part of the class is going to be registering for the test. I'm going to pass out the paperwork. We're going to go over all of the test requirements in just a few minutes. But I want to talk to you a little bit about diabetes, because that's really why we're doing this, is because our diabetic patients often have wounds that they don't even know are there. For instance, if I stepped on something sharp, I would know, my foot would tell me, oh my gosh, you stepped on something sharp. I'm probably hopping around. I'm going to try to look at my foot to see what's there. I'm aware of it. But with diabetes, a lot of times your patients will have injuries that they aren't even aware of. And I have to explain to you how that happens. So every cell in your body runs on glucose. And the way we get glucose, your mitochondria need it to convert ATP. It's a whole string of events, okay? But you need glucose in your cells. Glucose can't get into the cells by itself. You eat carbohydrates. Our society, carbs have a bad rap. Carbs are not bad. Carbs in excess are bad. Carbs are actually needed by the body. So you take in carbs, they break down into sugar. And that sugar goes into your bloodstream, but it stays in the bloodstream. It doesn't go into the cells on its own. That cell is locked, and what we need is a key to unlock the cells. Now, that key is actually made by your body, by your pancreas in your body, and it's called insulin. So you eat carbohydrates, breaks down into sugar, your pancreas produces insulin. Insulin goes into the bloodstream, opens up the cell, and the glucose goes in. Cell is happy now, can do what it needs to do. The blood sugar in the bloodstream goes down because the sugar is in the cells. Now, if the patient doesn't produce insulin, if their pancreas isn't working, we eat carbs, they break down into sugar, sugar goes into the bloodstream, but it can't get into the cells. So our sugar in our bloodstream rises because that sugar can't get into the cell. It's now stuck in the bloodstream. So we end up with high blood sugar. Make sense? If we could just get that sugar into the cells where it needs to be, the level of sugar in the blood would go down because now that's in the cells. But the problem is we can't unlock the cells. Now, in the meantime, those cells are starving, dying because they're not getting energy. So we have dying cells and we have sugar in the bloodstream that can't get into the cells. Good so far? With me? All right, this is where it gets a little crazy. So your cells are screaming at your brain, I'm dying. I'm literally dying here. You've got to get me some fuel. So the brain says, we're hungry, and triggers a craving. Now, this diabetic patient isn't going to crave chicken or ground beef or it's going to crave what? What do diabetic patients crave? Sugar. And the reason they crave sugar is because their cells are dying and the brain is trying to get sugar to the cells. So your diabetic patients will pick up donuts or M&Ms or, something like that that's going to bring sugar on board because their cells are dying. The problem is that we didn't give them any keys. It's not a sugar problem. It's a key problem, an insulin problem. Do you see the problem there? So we dump more sugar in the system, raises our blood sugar even more, and the cells are still dying. So your diabetic patients will crave sugar. It's perfectly normal, very natural because their cells are dying. But on the back of every cell is a little tiny back door. Not as efficient. Doesn't work as well, but it does work. If you can get your diabetic patients that are eating sugar and they know they shouldn't, but they're responding to a very real crisis in their body, their cells are dying. If you can get them to pair protein with that carb that they're eating. So instead of a chocolate donut, how about an apple and some cheese? Or a half a peanut butter sandwich? Or graham crackers and peanut butter? Or tuna salad? Get them to pair a protein with that carb. That protein opens up a back door on the cell and allows some of that sugar to go in and fuel the cells. Not as efficient, but definitely helpful. And more importantly, it helps reduce those sugar cravings because now the cells aren't starving. CNAs often yell at patients, diabetic patients, for eating the wrong things. Like, oh my gosh, you're diabetic. Why are you eating a candy bar? Don't you know any better? You know, why are you doing this? Not understanding that the patient is literally dying. Their cells are dying. And all they're trying to do, all the brain is trying to do, is keep those cells alive. Now, the brain doesn't understand that it's not a sugar problem. It's an insulin problem. The brain doesn't have that piece of the puzzle. So instead of getting mad at your patients, much better to help them make better choices. Does that make sense? Cottage cheese and fruit is a fantastic solution to this because you get the protein, but you also get that sweet of the fruit, and it helps cut cravings. So it's a wonderful thing to suggest to a patient. Now, not everybody likes cottage cheese, but it definitely can help with that. A new trick I learned, I had no idea about this, but a new trick I learned with cottage cheese is put it in the blender. It makes it really creamy. And so people with texture, I have texture issues. It can help somebody that doesn't like cottage cheese be able to tolerate it. Okay. So does that make sense? All right, so let me explain to you what happens with all this excess blood sugar. A sugar is a crystal. Have you ever seen a crystal? You guys know what crystals look like? Like this is a crystal. See how sharp and jagged those things are? So this is what a sugar molecule would look like if we blew it up. It's sharp and jagged. So this is what's inside the bloodstream, floating around. So whatever comes across, you know, this is sharp. So it's going to catch a lot of stuff that's in the bloodstream. Like it's going to shred cells. It's going to kill some red blood cells. But these are heavy because we have gravity on planet Earth. So gravity is going to pull these sugar molecules down. And what's going to end up happening is that they're going to coat the inside of the arteries. And it makes the inside of the arteries hard and jagged and sharp. So everything inside that bloodstream is going to get all caught up in this crystal stuff. So we've got cholesterol, which looks like pizza cheese in your arteries. So you've got this big, clumpy, gluey mess in your artery. But when you're born, your arteries look like this. This is an amazing artery. I wish my arteries looked like this now. Wide open. Lots of blood can go through there. It can expand. It can contract. It can do all kinds of things. It's a good artery. But as we age, particularly in the United States, our arteries start to gunk up a little bit. And if you look close, you can see that the inside of this is a little narrower than this. Not a lot, but a little. And it's got a little gunk buildup here. Now, this isn't a huge change. This is just little. But this is a person that is noticing their blood pressure go up a little bit because remember, the pressure is the amount of pressure inside the artery. Well, if the artery is smaller hose, more pressure inside. Now, if we don't do something about this, if we ignore this, then, and we keep up with our eating habits, I'm going to talk to you about eating in just a minute, we end up with more of a gunk buildup. So this is middle age. This is what happens with all of that sugar and all of that cholesterol that starts to really gunk up our arteries. And there's not as much room there for blood to get through. So we have high blood pressure now. But we also are going to have difficulty healing from injury because we just can't get enough blood, good blood, to the area. In advanced diabetes, it gets to this point because of all those sugar molecules that have collected all the cholesterol and dead cells and everything else. It literally clogs your arteries up. Now, you see this red blob here? That is what should be blood that has clotted. Because when blood slows down or stops, it clots. So now I've got blood clots inside my arteries. Do you think that's good for anybody? No. So we've got a lot of problems here. And this is caused by diabetes. All these sugar molecules that aren't in the cells, they're clogging up the arteries. You guys see why that could be a problem? Gets worse. That's bad, but it gets worse because those sugar molecules don't just stay inside the arteries. They also coat the nerves. So if I have a wound on my foot and my system works fine, my foot knows the wound is there, but so does my brain because my foot told my brain through a nerve, hey, there's something here, check it out. And I take care of it. But with diabetes, if I have sugar molecules that are coating the nerves, now I can't get that signal from my foot to my brain. So my foot knows there's something wrong, but that signal never makes it to my brain. So I don't know there's something wrong. And this is why we do foot care. Because your patient, particularly diabetic patient, might have a wound on their foot that they don't even know is there. And that's why we're looking. Good. Many years ago, I was working as a agency nurse. That's a substitute nurse that goes into a facility when they don't have enough of their own nurses. And I was assigned to a rehab wing. So I went into, got report, went in to see my first patient. And when I walked in the patient's room, the lights were all off except for one small light above the bed. And as I walked in, I flipped the lights on to look at my patient because I got to do an assessment head to toe. And as soon as I flip the light on, he starts screaming, turn it off, turn it off. So I turned the light off and walked up to the bed and I said, hey, Henry, my name is Patty. I'm your nurse today and I need to do an assessment. Is there a reason why we don't want the light on? There's a reason. I mean, people don't just yell, turn the light off for no reason. So I'm thinking maybe he's got a headache or is nauseous or so. He says, no, I've got diabetic retinopathy and the bright light hurts my eyes. I don't like the bright lights on. Okay, no problem. So as I'm standing there talking to him, I'm catching an odor. And if you've ever smelled a wound, they're very distinctive. And I know this guy's probably got a wound somewhere. So as we're talking, I'm pulling out my report sheet and I'm taking a look and I don't see anything on the report sheet about a wound. Nothing. Great. So I tell him, hey, Henry, I think you've got a wound brewing somewhere. I need to take a quick peek. He says, do what you got to do. Now, this guy was in his 50s. He was gruff. He was a little rough around the edges, but pretty compliant. So I turned him over and I looked at all the usual suspects, the tips of the ears, the back of the head, the shoulder blades, the lower back or coccyx area, down the back of his legs. I'm not seeing anything. I get down to his feet and he's got those slipper socks on, you know, the kind with the dots on the bottom. And I tell him, Henry, I need to take your socks off and look at your feet. And he immediately barked, no. Now, I know where my wound is now, right? It's nowhere else. And he's not letting me take his socks off. So I turn up the charm because you can get further with patients by being nice than being mean. So I turn up the charm. And I get him to allow me to take his socks off. I took the first sock off, no problem. Foot was flaky, could use some foot care, a little lotion, but not in bad shape. Tried to take the second sock off and it stuck to the bottom of his foot. Found it. So I go get a big basin of warm salt water. We call it normal saline. And I put the whole foot, sock and all in the basin. I need to loosen that sock from the wound so I can take it off and see what I'm working with. I go take care of another patient, come back 10 minutes later, tried to take the sock off, and I've got to give it a little bit of pressure because it's still stuck. And as I'm pulling at the sock, something comes flying off of his foot. That's not good. So I'm counting toes. They're all there. What went flying off his foot? This. This is a flat white metal thumbtack. Now, this isn't the thumbtack that was in his foot, but one very similar. White metal flat thumbtack. Now, how was this dude walking around for God knows how long with a thumbtack in his foot and not know about it? Diabetes. So I look at the bottom of his foot. I know we've got a problem now. And at the bottom of his foot is an area about this big around, roughly, and it was hard, black, dead tissue. Now, we can heal a lot of things in healthcare. We're pretty good at healing stuff, but dead is dead. We're not Frankenstein. We can't use lightning and bring stuff back from the dead yet. It's coming, but we're not there yet. So I know this guy's got a long, hard road ahead of him. So I call the doctor, I take my pictures, I write it up, I get in touch with the wound care specialist, I called his family, I did everything I needed to do, and I left, not my patient, not my facility. Henry stayed on my mind, though, because this guy was only in his 50s, and that's awfully young to be facing something like this. So many, many months later, probably 8, 9, 10 months later, I don't know exactly how long, I go back to the same facility. This time I'm on the other side of the facility, the long-term care side. I'm getting report, and his name is on my sheet. Now, before he was in the rehab section, which meant he was supposed to go home. Now he's on the long-term care side, which means this is now his home. And he's in his 50s. And that's awfully sad. So you think this is what he wanted for retirement? No. He was probably thinking about margaritas on a sandy beach somewhere as retirement. This is not what he had in mind. So I go in and, hi, Henry, I'm Patty. I'm the nurse that found the wound on your foot many, many months ago. I was surprised to see you on my sheet today. How are you? And he pulled the sheet back, and he had to have a below-the-knee amputation. He lost his leg over this. Now, to me, this was particularly tragic. Number one, because the guy was so young. But number two, because it was completely preventable. Completely. 100% preventable. Because if he had been wearing shoes, where would the thumbtack be? We don't amputate shoes. Walking a patient without shoes should be criminal. That's how injuries happen. And injuries to a diabetic patient will cost them their foot. This was preventable. Slipper socks are not enough. Slipper socks did nothing to protect this guy. Nothing. Now, the real tragedy here is the fact that this wound was in place for a very long time before I found it. How did that happen? Well, remember, he didn't want the lights on in the room. So nobody was able to see his foot very well. The room stayed pretty dark. And he was wearing those slipper socks with the dots, and this just blended right in to those white dots. Now, the other problem is the CNA should have been doing foot care once a week. It was on the care plan. And the patient kept refusing foot care because he didn't like people touching his feet because he had neuropathy. Feels like ants on your feet, and somebody touching it hurts. He didn't want anybody touching his feet. And instead of the CNAs telling the nurse, hey, he won't let me do foot care, they just went, not my problem, and moved on. So we have no idea how long this guy had gone with nobody looking at his feet. He didn't know there was a wound there, and either did we, because of a cascade of events that could have resulted in him keeping his foot. So this is a failure on many levels. The nurses did not do a head-to-toe assessment like they were supposed to. The CNAs did not report that he would not let them do foot care. And somebody walked him without shoes. He's the one that paid the price. And he lost his leg. Do not walk a patient without feet, without shoes on their feet. Do not fail to report patient refusals to the nurse. Make sense? Good. That situation happened early in my career. Now, I've been a nurse for 35 years now. And this poor guy has been on my mind for that amount of time. Because we can do better than that. Help isn't help if it doesn't help. right? Does that make sense? Do you guys understand a little bit more? All right. So before I show you this skill, I want you to go to page 115 in your book. We're going to talk a little bit about teams reporting. I just told you guys that at the beginning of the shift, I got a report from the offgoing shift. And nowhere on that report was anything about a wound. Well, you guys as CNAs will also get report when you come on shift from the person going off shift. This is going to tell you a little bit about each one of your patients. And there isn't a organized way of getting report. Everybody does it a little bit different. There's no specific way it has to be done. And that leads to the potential for mistakes, things being missed, because there's no specific way a report has to be handled. Does that make sense? You're relying on getting care plan information from somebody else that might forget to give you an important piece of information. So this, what I'm giving you here, is the teams report. It is a way of organizing information in a way to make it easy to transfer information from one CNA to another and try to limit the amount of information that's missed. So teams is TEAMS, and each one of those letters stands for something. T is for toileting. You need to know how every one of your patients is going to toilet, because I guarantee they will have to go on your shift. Guaranteed. So how does that happen? Do you take them to the bathroom? Do they go on their own? Do they have a catheter? Do they use a bedpan? Do they use a bedside commode? How are we doing this, right? Toileting is the first thing you need to know about every one of your patients. The next thing you need to know is how do they eat? Because I guarantee you they're going to have to do that on your shift too. So are they on fluid restriction? Are we forcing fluids? Do you have to thicken their fluids? Are they on a soft diet? Are they in PO? Do they have to be fed? What do we need to know about their eating? Then we have ADLs. That's everything else. Dressing, grooming, bathing, all the other things we do. Then we have M for mobility. Now, mobility is a special category all on its own. You need to know your mobility needs of your patient. Are they bed bound? Do they get out of chair? Do we use a gait belt, a walker, a wheelchair? What are their mobility restrictions and needs? And then you have S for special. Now, wound care would be under S. Vital signs is going to be under special. Their family is coming to visit today. You would want to know that so you can get them looking extra dapper, right? Before their family comes. So S would be special. If you use this when you're getting report, it makes sure you know all of the pertinent information about each one of your patients and nothing gets missed. It's called the teams report. You don't have to use it, but I'm telling you, if you start implementing this, you will find that you're much more informed about your patients and nothing gets missed. Good? Questions? Okay. All right. Jacob, can we play the foot care video? Hello, good afternoon, Mr. Jones. My name is Patty, and I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. I'd like to perform foot care on your right foot per the care plan. Is that okay?
Yes.
Let me close your privacy curtain, wash my hands, and get my supplies, and I'll be right back. After washing my hands, we'll gather our supplies. We're going to start with a barrier on the floor under the patient's feet. So we'll spread the barrier out. And can you move your left foot to the side, please? Thank you. I'm just going to place this barrier on the floor. If you can lift your foot. Thank you very much. And we'll move that shoe out of the way. We'll also need a basin, soap, and lotion. Once the barrier is in place, we're going to get 1 towel and 2 washcloths and take them to the patient's area. You can place a barrier on the floor to kneel on, but this is optional. All right, Mr. Jones, I'm going to go get some water in the basin. I'm going to use a paper towel to turn the water on. Check the water temperature with the inside of my wrist. It should feel warm, not hot or cold, just warm. And we'll fill the basin about 1/4 of the way full. And then throw the paper towel away. Mr. Jones, would you like to check the water temperature?
Oh, that's beautiful.
Very good. I'm going to set this down. For this skill, I need 1 set of gloves. I'm going to go ahead and put my gloves on before we get started. And then I can take your sock off. We're just going to lift your foot and remove your sock. We'll set your sock to the side, being careful not to overextend, and place your foot into the basin. After your foot has soaked for a few moments, I'll place the washcloths in the basin and rinse your foot, and then lift the foot out and place it on the towel, wringing out one of the washcloths and applying soap. We'll apply soap to the top leaf and then wash all surfaces with short, soft strokes or a patting motion. We're going to wash down each one of the toes and then get in between the toes. And then gently we'll lift the foot with support and inspect the bottom of the foot while we wash all areas from top to bottom. And then we'll set this washcloth aside and place the foot back in the basin to rinse. We'll use the second washcloth to rinse the foot, squeezing the water to make sure that the foot has been rinsed well. I'm going to unfold the towel and lift the foot and place it on the towel to dry. We'll blot the foot dry around the ankle, the top of the foot, the heel of the foot, and then we'll lift the foot gently to dry the bottom. We'll take an edge of the towel and slide it gently in between each toe to blot to make sure no moisture remains behind. Now that the foot is dry, we'll get some lotion, warm it up in our hands, and then apply it to all areas of the foot except between the toes. So the top of the foot, the heel of the foot, and the sole of the foot, but not between the toes. And then we'll wipe off the excess lotion. The care plan has told us to replace the patient's sock. So once the lotion has been removed, I'll take the sock, make sure it's right side out, and scrunch it all the way up to the toe seam. We'll put the sock over the foot, making sure the toe seam lines up across the toes, and then we'll secure the sock over the heel, minimizing wrinkles and making sure the sock fits appropriately. And then we can gather our dirty linens and place them in the soiled linen hamper. So we'll place our soiled linens in the soiled linen hamper. Now we can clean our basin. I'll bring the basin to the sink. We will dispose of the water in the sink, rinse the basin, and then dispose of the rinsed water in the sink as well. I'm going to set the basin down, disinfect it per facility policy, and then use a paper towel to pick it up. We'll dry the inside with a paper towel. Throw that paper towel away. Dry the outside with a paper towel and throw that paper towel away. And then get one more for the drawer. After cleaning the basin, we'll use the paper towel to pick up the soap and the lotion and return the basin to storage. We're going to put our supplies away by opening the drawer with a paper towel. We're going to put the basin, soap, and lotion in the drawer. Close the drawer with a paper towel, and then we'll throw the paper towels away. And then we'll remove our gloves, being careful not to contaminate our hands. So now I'm going to gather the barrier, and we'll throw this away. And I'll help you put your shoe back on. There you go. Are you comfortable?
Yes.
Is there anything else I can get for you while I'm here?
No, thank you.
Would you like a magazine before I go?
No, thank you.
Your environment is clean. I'm going to go open the curtain and give you your call light.
Thank you.
Okay, Mr. Jones, here's your call light. If you should need anything at all, just press that red button. I'll be happy to come back and help you.
Thank you.
Is there anything else I can get for you before I wash my hands?
No, thank you.
Okay, have a great day. I'm going to go wash my hands. After washing my hands, I'll review the care plan, make any corrections, and tell the evaluator my skill is done. Okay. Any questions? Any questions?
So, we don't know what's on their feet, so we lift them up. So, question for the test, can we wear gloves?
You should wear gloves for this skill because you don't know. Because we're looking for a wound, which means we don't know if there's a wound. We're expecting to possibly find one, so we should wear gloves. Good. Questions? All right. We're going to move on to the last skill for today, and this is mouth care. There's not much to teach you. You guys already know how to brush your teeth. Right? There's not much here. The principles we're going to follow, of course, we're going to follow our care plan. We're going to do our opening. We will need gloves for this because we're working with body fluids, saliva. We need a barrier for the table. We're not going to hold the towel against our uniform, so linen rules apply. We're going to clean the basin the way we clean everything else, and we're going to do our closing. Not much there that's surprising or unusual. But when it comes to brushing somebody else's teeth, we have to think a little bit about safety, particularly if they're in bed. Okay. So page 93 gives you your step-by-step instructions. Your supplies are at the bottom of the page and your care plan is at the top of the page. So let's take a look at the care plan for this skill. It tells us a resident with natural teeth is lying in bed and needs mouth care. The resident is not able to provide their own mouth care. Guys, if you can brush your own teeth, you will. It would be very awkward for some stranger to come in and brush your teeth if you're perfectly capable of doing it yourself. That's just weird. And patients aren't going to want that either. So we're going to follow our care plan. If the care plan tells us to brush somebody's teeth, it means they can't do it. We're going to do a good job. Okay? Good? All right, so we know all the principles involved in the skill except for the skill specific. So we're going to go to that. We're going to follow that care plan. We're going to do our opening. We're going to get our gloves. We're going to use our barrier. We're not going to hold the linens against our uniform. We're going to clean our basin the way we clean everything else. But let's get into our skill specific steps here. If your patient is laying down in bed, is that a safe position? No, we need to get the head of the bed up. But here's the problem. We can't touch the patient until our hands are clean. You guys remember that? When you put the head of the bed up, that pillow is behind their head now, which forces the head forward. This is not a comfortable position, and it's not a safe position for mouth care. We've got to get that pillow from behind their head to behind their back, sliding it down. But we can't touch the patient until our hands are clean. Good? Make sense? Do you understand that rule? So we're going to do our whole opening. Knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I need to brush your teeth. Is that okay? Close curtain, wash hands. We're going to put the head of the bed up, but that bed controller may not be clean. So what is something I could use between the bed controller and my clean hand to keep my hand clean? A paper towel. That's right. So it doesn't matter when you put the head, you can go get your supplies first and then put the head of the bed up, or you can put the head of the bed up and then go get your supplies. It doesn't matter. Test doesn't care. But use a paper towel between your clean hand and the bed controller. Make sense? Good. I generally get my supplies first because that's just the routine. Okay. I wash my hands, I get my supplies. Those two things always go together. And then I put the head of the bed up right before I start, and then I can slide the pillow down. Okay. Head of the bed up is a critical checkpoint. If you don't put the head of the bed up, you will fail the test because you killed your patient. So we're going to, if you look at your step-by-step instructions, step 7 tells you how to put the head of the bed up with that barrier. It's in your book. It'll also be in the video as well. Once you got the patient in a sitting position, we're going to put a towel over their chest that just collects any saliva or toothpaste that might drip down. It is a tested checkpoint. You're going to wet your toothbrush before you put toothpaste on it. That is a tested checkpoint to wet the toothbrush first. We're going to brush whatever they got. This is it. So everybody gets like all caught up with the brushing thing. Well, do you have to do 2 minutes? Do you have to do the front first or the back first? This is it. This is your whole checkpoint on brushing teeth. It says brush sides and biting surfaces of teeth and the gum line with a gentle motion. That's it. That is your mouth care brushing teeth checkpoint. That's all it says. So they don't care. They don't care. We're going to offer them a cup of water to rinse as often as they need to. Guys, if you put a lot of toothpaste on that toothbrush, they're going to be rinsing forever. Little bit of toothpaste is all you need. Let them rinse. Give them something to spit in. For the test, you're probably going to use an emesis basin. This is what we recommend that you use. It's in the top drawer. This will hold water very well. Holds quite a bit of it. Saliva from them spitting. The test also allows you to use a disposable cup for them to spit into. But cups are kind of tricky. A lot of people don't want to spit into a cup. It's just a little gross for them. Spitting into a basin is mentally much more comfortable. Good, makes sense? Either one will work for the test. In the demonstration, you'll see me use this. So you let them rinse and spit as much as they need to. We want to leave their mouth dry. This is a step that's missed on the state exam all the time. All the time. People forget to dry their mouth off. So they've rinsed, they've spit, and now they're a drippy, wet mess. Well, you go clean stuff. Don't forget to look at your patient. And then you'll do your closing. That's it. That's the whole skill. There's nothing here. It's super easy. But it's a little weird to have somebody else brush your teeth. It is a little weird.
During test day, do we brush
You
teeth?
will be a patient and you will really brush somebody else's teeth for real if you get this skill. But remember, there's 20 skills. You're going to get 3 out of those 20. You probably won't get this skill, but you might. You probably won't get this skill, but you might. You're only going to get 3. So chances are you probably won't get this one, but we have to know how. Good? Questions? All right. So remember that we only brush teeth for people that can't brush their own. And if you're going to brush somebody's teeth, do a good job. Do a good job. There was a young man who was in a motorcycle accident, again, a million years ago. But he was in the ICU. It was closed head injury, wasn't wearing a helmet, hit a tree head first. It was really touch and go for a while. They almost lost him a couple times. He broke his neck. He was paralyzed from mid-chest down. When he got up to the step-down unit that I was working on, I noticed that every time I talked to him, when he went to answer, he always turned his head away. Or he gave me one-word answers, or he just really minimized how much he was talking. And at first I thought, well, maybe this guy's depressed. I mean, his whole life is now altered. He's paralyzed. This is not, he was maybe 19, 20. This is not a good situation. Maybe he's depressed. Maybe I need to get a psych consult for him. But I started digging a little bit deeper and asked him some very specific questions. And what he said to me broke my heart. It came out that he didn't want to talk because nobody had brushed his teeth in the 6 or 8 weeks that he had been in the hospital. He had not had his teeth brushed since before the accident. Now, he knew he had dragon breath, and he was afraid of offending me. This guy has had his entire life altered, and all he can think about is his breath. That's horrible. We can do better than that. So if you're taking care of somebody and you know they can't brush their own teeth and you're not doing it, who's doing it? You need to be bringing this up to the nurse. Hey, mouth care? Because there's a possibility that the nurse is so focused on labs and physical therapy and surgery and all those higher level things that the nurse has to think about. She probably never even thought about mouth care. But you can, and you can bring it up to them. Good? This guy ended up losing a whole bunch of his teeth because of this. So now on top of, all the trauma from the accident, now he's got to go through oral surgery. How horrible is that? Horrible. We can do better. Help isn't help if it doesn't help. All right, so we're going to follow this care plan exactly because it is for this patient. I apologize, guys. I can't do anything about that. I'm trying to compete. But let's watch this last video. While the video is playing, Jake's going to be passing out the test registration packets. We're going to go through them in class together. But I want you to remember that the last hour of class 4 is what you're going to go back to review for test registration instructions, because you will forget some of the stuff that I have to tell you today. So remember, the last hour of class 4 is on test registration. Yes. Yep. All right, Jake, go ahead and put this one on. What's that? We're actually going to give you the links for that. I do have one. I'm sorry. I still have respirations to go. I forgot. I have one more skill to show you. No, go ahead. Go ahead.
Hello.
Good morning, Mr. Jones. How are you?
I'm well. How are you?
Fantastic. I'd like to perform mouth care on you. Is that okay?
Yes.
I'm going to close the curtain, wash my hands, get my supplies, and I'll be right back. I'm going to use a paper towel as a barrier to put the head of the bed up, since my hands are clean and the bed controller is not. Once we get the patient to an upright sitting position, I can throw the barrier away and then adjust the pillow so it's a little more behind his back rather than his head. There we go. Good?
Yes.
Okay, let me go get the rest of my supplies and I'll be right back. I'll gather my supplies. We're going to start with a barrier, and that gives us a clean place to place our clean supplies. So we're going to open the barrier up. And I also need a towel. We're going to get an emesis basin, a toothbrush, toothpaste, and a cup of water. And we also need a pair of gloves. I'm going to get my toothbrush prepared by wetting it and putting toothpaste on, and then storing it in the emesis basin until I'm ready to use it. Mr. Jones, can I place this towel over your chest?
Yes, please.
Thank you. This is just going to help keep your clothing clean. I'll put my gloves on. And now we're ready to brush your teeth. I'm going to brush the top, the bottom, the front, the back, and your tongue. So can you open wide for me? I'll start in the back, on the top, both sides, and then the bottom, both sides, the front, both top and bottom. And can you bring your teeth together? Thank you very much. And then stick your tongue out. Thank you. I'll set this aside, and now we can rinse. Go ahead and take a sip. Another sip.
Yes, please.
Okay. I'll pour the water in the emesis basin, set them on the table, and then I'll take this towel away and put it in dirty linen. I'm going to go clean my basin. We'll clean the emesis basin by dumping the saliva into the sink, rinsing the basin, setting it down, and disinfecting per facility policy. Then we'll take a paper towel to pick it up, a paper towel to dry the inside. We'll throw that paper towel away. Paper towel to dry the outside, throw that paper towel away, and one for the drawer. Now I can return the basin to storage, putting the toothpaste in the basin and using a paper towel to open the drawer to store the basin back in it. We'll close the drawer with a paper towel and then throw those paper towels away. All of these disposables will be disposed of. I'm going to go throw this away. I'll be right back.
Okay.
Now I can remove my gloves. Okay, Mr. Jones, is there anything else I can get for you while I'm here?
No, thank you.
Are you comfortable?
Yes.
Okay. Bed is in the low position. Your environment is clean. Let me get your call light for you. Would you like a magazine before I go?
No, thank you.
Okay. Here's your call light. If you need anything at all, just press that red button. We'll be happy to come in and help. I'm going to go open your curtain and wash my hands. After washing my hands, I'll review the care plan, make any corrections, and then tell the evaluator my skill is done. I got it. All right. So one of the things that I want to bring to your attention with that particular skill is at the end of the skill, it does not matter whether your patient is sitting up or laying down. It's whatever the patient wants. So we can leave them sitting up. If they want to lay down, we can lay them down. The beginning of the skill, the head of the bed has to be up for safety. But at the end of the skill, it's whatever the patient wants. Okay. Good. All right, so let's learn respirations. This is a quick skill. This takes, I don't know, maybe 5 minutes for me to teach you. Page 54 has all of the principles, nothing to learn here. Page 55 has our care plan, our supplies, and our step-by-step directions. Let's take a look at the care plan. Care plan says patient will be laying in bed for the skill, count the patient's respirations for 1 full minute, and record your readings. That's it. We're counting their breathing for 1 full minute. That's the whole skill. Put an opening in front, a closing behind. That's the whole skill. But there are a few things with this skill that we need to be aware of. Some things that make it a little more challenging. The first thing that you need to know, well, let's go through this. We're going to follow the care plan. We're going to do our opening. We're going to evaluate if we need gloves. We're not touching body fluids, not touching non-intact skin, not touching personal skin. So chances are you do not need gloves for this. But if any of those do apply, wear gloves. The first thing we need to know about respirations is you can't tell somebody you're counting their breathing. If you tell them, I'm going to count your breathing, ready, set, go. Patients will either stop breathing or they'll start breathing fast. So we don't want to tell our patients we're counting their breathing. What we're going to say is, I'm going to take your vital signs. Breathing is part of vital signs. We're not lying, but we're not being overly specific either. We also don't want to just stare at somebody without touching them. That's weird. Like, this patient's going to get all kinds of uncomfortable if I do that. So to do this skill, I'm actually going to make my patient think that I'm taking their pulse. So I'm not finding their pulse. I'm not doing anything really but holding their hand. But this makes them feel much more comfortable when I'm looking at their chest or their abdomen, watching their breathing, than if I did this. You guys see the difference? Okay. All right. In and out is going to be counted as 1 cycle. So that's 1. Doesn't matter whether you start counting on the in or the out. Doesn't, if any part of that is there, it counts, because the whole thing counts as 1. Normal is between 12 and 20. Now we're going to count for 1 full minute because our care plan tells us to count for 1 full minute, but this is just like pulse. We can take shortcuts. 15 seconds multiplied by 4, as long as our care plan doesn't say 1 full minute. This care plan does. So how long are we counting for? 1 full minute. Okay, so we're going to count as long as that care plan tells us to count. If it doesn't specify, you can use 15 seconds and multiply by 4. Normal is between 12 and 20. For the test, you get 2 breaths in either direction as your variance. What that means is if the evaluator got 16, if you got 14, 15, 16, 17, or 18, you're still in the ballpark and you're fine. That's a huge margin of error, guys. Considering normal is between 12 and 20, and you're getting most of that as a variance. And don't forget to document during this skill. So we're going to do our closing, wash our hands, document, and wash our hands again. So that's everything you need to know about respirations. That's it. Page 48 is going to talk to you about documentation principles. I'm going to have you read that on your own. So page 48, you'll want to make sure that you read this at home this weekend. All right. Remember, this care plan is just for this patient. Jacob, go ahead. Oh, so Jake's going to show you this video on respirations. It's a 2-minute video, literally 2 minutes. But during this video, I have zeroed in on the patient. You're going to be able to see him breathe. I want you to count the respirations along with what you see on the screen. To make it even easier, on the bottom of the screen, kind of like the pulse, I actually have the words getting bigger when he inhales and shrinking when he exhales. So you can visually see the inhale and exhale using the words on the bottom of the screen. So count along with me while you see him breathing, and see at the end whether you got the same number that I report. Okay. You don't, for this skill, it's going to be done on a live patient. One of you guys might be in the bed. You'll know that your respirations are being counted. Try to normalize your breathing a little bit, even though you know somebody's counting it, just to make it a little easier for the person being tested. Okay. All right, Jake, go ahead.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. I need to get your vital signs. Is that okay?
Yes.
I'm going to close your curtain. Let me go wash my hands, and I'll be right back. Okay, Mr. Jones, I'm just going to lay this on your stomach for later. I'm going to elevate your forearm, keeping your elbow on the bed. And this will take me about a minute. I'll need you to remain quiet during that time, but I'll let you know as soon as I'm done, okay? And we're going to start. Ready, set, start. Stop. Thank you very much, Mr. Jones. Is there anything else I can get for you while I'm here?
No, thank you.
Are you comfortable?
Yes, ma'am.
Would you like a magazine before I go?
No, thank you.
Okay, bed's in the low position. The environment is clean. Here's your call light. If you need anything at all, just press that red button. We'll be happy to help you. I'm going to go ahead and open the curtain and throw my alcohol pad away and wash my hands. After washing my hands, I'm going to document on the sheet provided by the evaluator and then wash my hands again. After washing my hands a final time, I'm going to review the care plan, think about my skill, make any corrections, and then tell the evaluator my skill is done. but it satisfies them enough that they're okay with it. If they insist, but what are you going to use that for? I can just say, it helps me with my count. That's all I say. They don't need to know what I'm counting. It just helps me with my count. And again, they'll say, oh, okay. We kind of capitalize on their ignorance. Make sense? Good? All right, so now let's go through test registration. On my website, you're probably going to want to write this down. On my website, on 4YourCNA.com, I've got this menu at the top. I have CNA training, testing, and after certification. Under this testing menu, if you click on it, it'll open up and there's test registration instructions. This is a step-by-step how to fill out the form you just were handed. I've got screenshots, step-by-step instructions. I do a whole video on there filling out the form. And then below the video is a slide-based presentation where you get to control the speed. So read the slide, do the step, go to the next slide. All of that is there for you. Now, we're going to go through it in class now, but all of that is there for you. Okay? So I'm going to answer that in about 2 minutes. Let me get a packet here so I've got it. Okay, so this page right here is where we're going to start. So the packet that I gave you, you have a single sheet of paper. This is for your background check. This is the packet for test registration. So background check, single sheet, packet, test registration. So the front of the test registration is this page. And this gives us our timeline. It also provides a lot of important information. This highlighted row, right in the middle, this is important. Highlighted is important. Each step has an important component to it that you need to be aware of, otherwise you'll make mistakes. So if you look at this and you look at the timeline, so it tells you do step 1 and then there's a little calendar. And then we have step 2 and then there's a little calendar. And then we have step 3 and a little calendar. This is our timeline. So we should go get our background check and 2 to 3 days later register for the test. Then about 1 to 3 days, we're going to get an email from Prometric. And then usually about 7 to 10 days, we're going to get another email from Prometric, but it can take up to 30. So if we fill this registration packet out today in class, and we do our background check, and then 2 to 3 days later, we register for the test, you should be testing about a week or 2 after graduation. So my suggestion is, if your funds allow for it, register for the background check today, go take it tomorrow, register for the test on Friday, and you should be testing about a week or 2 after graduation. That's the timeline. Now, some of you aren't going to be able to make that timeline. You're waiting on paychecks, or you have a vacation, or whatever the case may be, and you may have to adjust your timing accordingly. But in general, you will be testing 3 to 4 weeks from the time you submit your application. Remember, we're in week 2 right now. So if you register now, we still have 2 weeks to go for class, and then another week or 2 until testing. That's that 3 to 4 weeks. Does that answer your question? Yeah. Okay. So each one of these is a step. So step 1 is the background check. Step 2 is the application. Step 3 is waiting for an email from Prometric, which we have to look at to make sure everything's okay. And then step 4 is our test admission letter. So let's go through each one of these step by step. So all of this information is found on Prometric's website. This is prometric.com/exams/nurseaid-FL. So if you're in a different state, let's say you're in New York. New York also uses Prometric. This would not be FL, it would be NY. If you're in Texas, it would not be FL, it would be TX. So Prometric tests in, I think they're down to 11 states now. So each state is going to have a page similar to this. Prometric is uniform across all states. So when you go to this page for Florida, which is the one that applies to us, you're going to see this. There's a whole bunch of accordions here. It tells you a little bit about the exam here, but each one of these opens up. When you click on it to open it, if you click on application process and you open that, it tells you how the process works, step by step. It also has a link for the online application and the paper application. The paper application is what you guys have in front of you. I printed it out for you. Online, way quicker. It's the exact same form. So what we're going to fill out in class today, just use it as a template and put all that information in the online, and it goes a lot quicker. But if you want to mail in the paper one, you can. Either way. Okay? So before you do that, though, we need a background check. Because the process, I'm going to go through here, the process is that when you register for the test, they go into something called the clearinghouse, which is nothing more than a big filing cabinet, and they look for your background check. If you don't have one here, the whole application process stops. Stops, dead, in the water. So we need to make sure that we're in here before we fill out our application. That way the process goes really smoothly and quickly. So how do we do this? Let's start there. We need a level 2, well, let me go back here. We need a level 2 background, which is fingerprints, photo, and signature. Some of you have a background check for daycare or for working in the school system or for working in banking, or there's a lot of industries that require a background check. You need to make sure that you have a level 2 background check for healthcare that has all 3 of these. If your answer is not, yes, I definitely have one of those, you should go get one. Some of you worked in assisted living. Well, some assisted living is in the clearinghouse. Others are through ACA. There's no way for you to know. There's no way for you to look to see if you're in the clearinghouse. So if you're not 100% sure, go get one. Because Florida is very specific. We voted on this about 8 years ago. About 8 years ago, because these background checks, man, they are busy all the time. And the same people are getting the background checks done all the time, because every employer that you work for, you have to have a background check done. Every certification exam, you have to have a background check done. If you're a realtor, you got to have a background check done. I mean, every industry has background checks. And we were seeing the same people over and over and over. And it was just like this huge thing. So what they were saying, what they asked the voters is it okay if you get one background check and everybody gets to access it? Is that okay? And Florida said, no, absolutely not. So now you have to get an industry specific background check. They will let people in the industry access it, but nobody else. So you need to make sure you've got a medical level 2 with photo. I know, to me, it's just kind of silly. Just do one. Let everybody access it. It just would make things a lot easier. Okay, so you're going to go get your level 2 background check. The single sheet of paper I gave you, this, is how we recommend you do your level 2 background check. Some people are going to try to shortcut this and go to the sheriff's department. Every time I have a student that goes to the sheriff's department, there is a problem. I called them up and they said, yes, we do level 2 background checks for certification exams. We do the photo one. I checked with them, but every time I have a student that goes to the sheriff's department, there's a problem and testing gets delayed. It's cheaper to go to the sheriff's department, absolutely, 100% cheaper, but understand that you might be delaying your test. So if your test date isn't important to you, then you can try it. But if your test date is important to you, go here. This is immediate. I know this process works. Good. Now, this came directly from Deontis. They use the UPS store on Barclay. This came directly from them. I contacted them and I said, I need step-by-step instructions for my students. And this is what they sent me. So this will get you exactly where you need to go. Okay. All right. So this is the process. So you understand, this is an overview real quick of how this whole thing works. You get your level 2 background check done. Once you do that, then you apply to test with Prometric. When Prometric gets your application, they're going to go to that clearinghouse and pull your background check. They put it with your application as a package. So application, background check together, and that gets sent to the Board of Nursing. This is an eyes-on event, a human event. This packet gets sent to the Board of Nursing, and somebody, some individual looks at your background check and your packet and makes sure that you are a safe bet, that you're not going to murder grandma with a candlestick in the middle of the night. They have to make sure that you're a safe bet. Once they do that, once the Board of Nursing says, okay, no problem, they're going to send a test authorization to Prometric. Basically, they're saying, yes, this person, good to go. Now, when Prometric gets that test authorization, they're going to notify you. They're going to say, hey, Board of Nursing said you're okay. Now, you don't have your test date yet. All they're telling you is Board of Nursing said you're okay. Then Prometric will contract with the test locations, find the closest one with the fastest date. They will make that appointment for you, and then they will notify you of your test date. So you're going to get 2 emails from Prometric. One, the first one, within 1 to 3 days. I'm sorry, you get 3 emails from Prometric. The first one, within 1 to 3 days, it says, hey, we got your application. Everything looks good. We're sending it to the Board of Nursing. The second one says, hey, we heard back from the Board of Nursing. You're cleared. The third one says, here's your test date. All of that should happen usually within about 10 to 14 business days, 2 to 3 weeks. Now, when you get that email, that test admission email, the test date email from Prometric, they don't give you a lot of notice. They'll send you an email on Monday that says you're testing Sunday. You don't get a lot of notice. They don't take reservations. You don't get to make an appointment. They tell you, here's your test date. If that date doesn't work for you, you can call up Prometric, say, that date doesn't work for me. I need a different one. And while you're on the phone with them, they'll work out a date that will work for you. But you don't get to make a reservation up front. You take what they give you. If that doesn't work, then you call them. But you got to call them right away. Because if you get an email on Monday, it says, hey, you're testing on Sunday, and you wait till Saturday to call, they're going to charge you. Because now that spot can't be given to somebody else. And now instead of testing 7 people, we're only testing 8 people, we're only testing 7. Make sense? Good? You guys understand this process? All right. Okay, so this is Deontis. This is the website you're going to go to for your background check. When you go to this website, it's a little confusing at first because this is what it looks like. And you've got a couple of different options and you're not real sure what to click on. You want to click on right here where it says register and schedule a fingerprint appointment. And it's going to take you to this page. Now you got 4 options there. Which one do I pick? You want to pick new individuals because you have to create an account. So you want to hit register and new. When you do that, it's going to give you one of these create an account page. This is one of those super secret passwords that everybody has a hard time creating with letters and numbers and symbols and all of that. Just create a super secret password. And these are the instructions I just gave you. Generally speaking, you can get same-day appointments or even next-day appointments. It's going to cost you just under $78 to do your background check.
During testing, we do both the written exam and skills.
Right. Both written and skills.
If we already have an account, so we'll just use the account.
Yep. If you've already got an account on Deontis, use it. Absolutely. You'll have to do a new background check every 5 years. It'll be part of your renewal. I just had to get mine done this year for my renewal. So every 5 years, you've got to do another background check. All right. So that's the background check. We're done with background check. We went and got it. They took our picture. They took our fingerprints. We got all that done. They're not going to give you anything. You don't send anything anywhere. You just go to the appointment. That's it. Now, test registration. First thing I want you to know is how to contact Prometric. This is on their website. It has their contact information. But I want you to pay attention to this circled area. It says, if it has been more than 5 business days since you submitted an application and you did not receive any emails from Prometric, you need to contact them because something went wrong. Either there's a typo in your email address or it went to your spam folder or it got blocked or whatever. You need to contact them. I had a student about this time last year who took my class and didn't come back to tell me until January that she applied for the test but never got anything back from them. And it had been 6 months. So I had her contact Prometric on the phone while she was standing there with me. Her test date had come and gone. But all of the notifications were sent to her spam folder and she never checked it. So Prometric went through the process. She was approved for testing. She got her test date. It had come and gone. And she's like, well, what do I do now? I can't, do I get a refund? They said, no. Why would we refund you? We did our job. So she had to come up with another $155 to test. And that's a lot of money. Make sure that you keep up with this. This is your responsibility, not Prometric's. Okay? $155, a lot of money, guys. Don't throw it away. All right. So, under Prometric's website, we looked at application process, but there's another drop-down menu under candidate resources. And here we also have a link for the online and the paper application. They're here too. But just below it, you've got to track the status of my application. So if you're not hearing anything from Prometric, you need to use this link to sign in to see where your application is in the process. Keep up with this. Okay. All right, so let's go to the actual application, which is this packet. Okay, this packet. Go past page 1. Go past page 2. And on the back side, you'll see this page. On the back side of the second sheet, you'll see this page. This is where we're at. Okay, find this page. This is the paper application. The first thing you see is a stop sign. It says, please make sure that the name on your registration packet matches the name on your ID. You need 2 forms of ID to take the test. one with a picture and one with a signature. So your driver's license and social security card, or a passport and a debit card. Both IDs have to have the same name. Any questions on that? Please make sure that your IDs are not expired. That happened to a student not too long ago. She was turned away for testing because her driver's license had expired. So they can't use it. Please make sure your ID is not expired. So make sure you have 2 forms with the same name. And this box here is for ADA accommodations. This means you need a seeing eye dog or a sign language interpreter or something like that. You would check yes, and then there's a whole packet of information you have to print out and take to your doctor and have them fill out for accommodations. Now we're going to get into the actual candidate information. Now, I'm not going to have you guys fill this part out here in class. You can do this at home on your own. You know your name, your address, your phone number, and all of that. Fill out your candidate information. There's nothing there that's surprising. And the top of the next page. So just complete all of your demographic details when you are ready to do so. Let's go down here to this section, because this is the part you're going to need help with. So right now I'm under this, the title is Criminal and Medicare, Medicaid, Medicare fraud questions. Everybody with me on this section? Okay, if you have a felony in your background, if you have a felony, you need to see me after class. If you have no felonies, for number 1, check no. Skip A, B, C, D, and E. Do not answer those. Just check no for number 1, because number 1 has to do with felonies. Number 2 at the bottom also has to do with a felony. So if you have a felony, see me after class. No felonies, check no for number 2. So number 1 and number 2 should have a no with nothing else. Everybody with me? All right, turn the page. Now let's go to number 3. 3, 4, and 5 all have to do with a very specific situation. So let me explain to you what the situation is, and you can decide whether it applies to you. This is all about Medicare and Medicaid fraud from a provider standpoint, not a user, not a beneficiary, a provider. So if you worked for a doctor who fraudulently billed Medicare, and they just did a huge sting, something like hundreds of millions of dollars. Yeah, crazy amounts of money. So doctors and nurse practitioners do this kind of stuff. They fraudulently bill for services. If you worked for that doctor and you were part of this and you benefited from it, and the government took you to court and said you are not allowed to work with medicine ever again, these 3 things would apply to you. If none of that happened, if you did not work for a doctor who was convicted of Medicare fraud and you were taken to court and put on a list and told not to work in medicine ever again, then your answers for 3, 4, and 5 are no. Leave your A's, B's, C's, and D's blank. Any questions on that section? It has nothing to do with you getting Medicaid as a recipient. Has nothing to do with that. All right, now let's go down to disciplinary history. What this means, they want to make sure that you weren't a CNA in Indiana, knocked around some old people, got your certification taken away, and decided to move to Florida and do it here. So what this is asking is, have you ever had disciplinary action taken against a medical certification in Florida or any other state? If you've never been a medical provider, your answers are no. If you have any questions, see me after class. But those of you who have never had a medical certification, your answers are no. If you have, read and answer each question. Now let's move on to criminal history. This one is pretty cut and dried. There's only two choices here. It's asking, do you have a criminal history? Yes or no. If the answer is maybe, it's probably yes. Okay. There's only two choices here, yes or no. I know this question screws up a lot of people. Yes or no. Now, the next question asks if you've ever had any records sealed or expunged, which means you paid a lawyer $5,000 to make it all disappear. He didn't. We're going to find it. It's that simple. Lawyers will promise you up and down, nobody will ever see this record ever, except for us. Yeah, because we're saying that you are safe to go into grandma's house unsupervised. We don't want you bashing her over the head with her candlesticks. We got to know. So this is asking, have you ever had any records sealed or expunged? The last question there is juvie records. Do you have juvie records? Everybody was young and dumb. Everybody was young and dumb. Not everybody got caught. They're just asking, did you get caught? Now, the next question that I get a lot is, what happens if I do have a criminal history? Will that keep me from testing? And the answer is, well, it might, but it's not automatic. They look at everything on a case-by-case basis. And they look at the number of offenses, the severity of the offenses, and how long ago those offenses were. So let me give you some examples. Let's say that you shoplifted from Walmart, but it was over $500, so it ended up being pretty serious. And it was 8 years ago. You did your community service, you paid your fines, you did all the things you needed to do, but it was pretty serious. All right, the state is going to look at that. That was a single event, even though it was kind of serious. It was a single event. You made restitution, you did what you were supposed to do, you've been clean since. That's going to be looked at completely differently than somebody who has 12 shoplifting charges on their record, and the last one was 3 months ago, even though they're all minor. Do you guys see how those two might be looked at a little bit differently? Okay. Each charge, each conviction, and that's what they look at, are the convictions, is going to count a little bit differently. They're going to look at the severity, the frequency, and whether you made restitution and how long it's been. Okay, they're looking for patterns. It's not an automatic, you are disqualified. They've got a lot of things that they do to help clear you. So let's say we've got the lady that was a shoplifting kleptomaniac, 12 charges, last one 3 months ago. She wants to be a CNA. They're not going to automatically say, no, you don't qualify. What they will do is they're going to send that person an email, say, tell us more. Why? What happened here? What's going on? What's your side of the story? And then they're probably going to invite that person to come to a board of nursing meeting to meet the board, so the board can kind of get a sense of who they are and whether they're truly legitimate about turning a new leaf. Okay. Then they'll make a determination. All right. The next page, the title is Health History, Mandatory. I cannot help you with this page. I am not allowed to help you with this page. You would read the questions and answer them appropriately. But let me explain to you why I can't help you with this. Healthcare is stressful. Healthcare is a stressful industry. If you have difficulty regulating your stress reactions without being in a stressful industry, healthcare may not be the place for you. It's that simple. We don't need you in crisis while our patients are in crisis. You're not going to be any help to the patient. So they're going to ask you some questions about this. Good? All right. At the bottom of that page, you have to enter your Social Security number. Everybody has to have a Social Security number in order to test. And then if you go back to this page on the very front of that packet, down here, right down here, I have a video on the background screening. So that will help you understand how that whole process works. Okay, so at the top of page 5 of your packet, at the bottom it says page 5. At the top up here, I've already checked that off for you. Already checked that off. You have E3 Challenger checked off there. That is mandatory. You have to register as E3 Challenger. Yes, I know you're sitting in a classroom. This does not meet the 120-hour requirements. So everybody will register as a Challenger, but you're in good company. 88% of all people testing are Challengers. Hardly anybody. The only people that go through a school right now are high schoolers. Those are the only people that actually complete a 120-hour program. Everybody else is a Challenger. So we're going to check off E3 Challenger. Nothing else, just E3 Challenger. And then below that, where it says training information, I've got a big X there for you. We're not filling that out. We only fill that out if we checked E1 or E2. What did we check? E3. That does not apply to us. And we're going to go down to the next section, and we're all going to test at a regional test site. I've already checked that off for you too. Now, next to this, right here, it's asking for a test site code. If you register online, if you take this packet and just transfer everything online and register online, there's going to be a drop-down box. If you send in this paper application, you have to have a code to put in here. So where do you find the code? It's at the very beginning of this packet. So the very beginning of the packet. Remember, this is our front page, right? Just open it up. These 2 pages right here, these 2 pages are our test site lists. I broke it up into regions for you. We're in the central region. I broke this up into regions. So our closest one for us is at the bottom of the first page, where it says CNA TAMAIR. Yep, it's Tampa, near the airport. It's on Waters Avenue. It's called Gillis. That is our closest testing center. So we would put that code, CNA TAMAIR, in this box if we're going to mail in our paper application. Those of you from Citrus, there's a couple in Ocala. You can choose one of those. Good. If you're doing this online, there's a drop-down box. You would just choose the one. Gillis is first on the list, actually, because it's alphabetical. Makes it easy for us. All right, now, below that is our test. Okay. Below that is our testing fees. We are first-time testers. We have to take both the written and the skills on the same day. So first-time testers are going to check that first box. First-time testers check the first box. Now, unless if English is not your language, or you have a reading disability or dyslexia or something like that, and you want the computer to read the written test to you, you can check the second box. So the first box is just the plain test. Second box has the computer read the written test questions to you. If you want the written test in Spanish, there's another option down further that you can choose. But for most of you, first-time testers, check the first box. Our fee is $155, and we have to pay that when we register. So if you send this paper application in, the very last page back here gives us a place to write our credit card information. Oops, sorry, right here. Gives us a place to write our credit card information in. You can also pay by money order or cashier's check. there's a place for that as well. If you're paying online, if you're doing the online application, it has to be a debit or credit card. Okay? But that's how much we're going to pay. Now, if we go to the next page, let's go here. If we go to the next page, there's a box. Yes, no. What that's saying is you have received and read these last 2 pages in the packet, these 2 pages. This is the FBI privacy policy. It says how they're going to use your background check to clear you for testing, what to do if there's a dispute. When you check this yes box, that says that you have received this page. You're going to read the affidavit. You're going to sign and date if you mail this in. If you're doing it online, there's nowhere to sign. It's just electronic. Good? Good? Okay. If you're doing this online, there's one more thing that you have to do that's not on the paper application. And it's a box you have to check. It's going to ask you, if we ask you for any supporting documentation, how are you going to send it to us? And there's 2 options, by mail or by fax. I don't care which one you check, just check one, because you can't finish the application out until you've checked a box there. Do you remember I said that if they have a question about your background check, they don't automatically dismiss you, they ask you for more information? Well, that's what that box is all about. They're saying, if we ask you for more information, how are you going to send it to us? Are you going to pop it in the mail, or are you going to fax it over? I don't care which one you check. Just check something there. Because if you don't, the application won't save. It's not on the paper application, though. They don't ask us that on the paper application. Any questions on that so far? One thing about the online, it's way faster. If you do the online application, this process goes really quick. If you do the paper application, add about 2 weeks onto the processing time that I told you, because it's got to physically mail to get there. Somebody's got to open it. Somebody's got to put all this into the computer. It takes time. Longer if you mail it, quicker if you're online. But online at the very bottom, there's going to be 2 buttons. One of them says save and one says submit. If you click save, it saves everything you put in but your payment information. It does not save that. So if you hit save, when you go back in after it saves and reloads, you have to enter all of your payment information again before you hit submit. Okay? Does that make sense? Okay. So once we have signed and dated, at the very bottom here, you've got this. This goes along with that timeline that I gave you. It says if you don't receive your authorization to test, your test date, email, within 10 to 14 business days of registering, you need to contact them. So remember, that's that 2 to 3 week processing time. So if you don't have a test date within 2 to 3 weeks, you have to call Prometric. Find out why. What's the holdup? But when you call Prometric, the person that answers the phone isn't going to be able to give you that information. They don't know. They're told to get you off the phone. That is their job. When they're hired, they are told, answer the phone, get them to hang up. That's their job. They're not going to be able to help you. They're going to give you answers like, yeah, it can take up to 6 months. Nowhere in this application, you read it like I did, nowhere in this application does it say 6 months. It's telling us 10 to 14 business days. So you want to quote this to them. My application says 10 to 14 business days. I need a supervisor. You've got to get past that person answering the phone. You have to get past them. Good? Questions? All right. Remember, this is their contract with you. Their contract says 10 to 14 days. Sometimes you have to remind them of their contract. All right. When you register for the test, 1 to 3 days later, you're going to get an email from Prometric. In that email, there's going to be a box that says application status. You need that to say complete. That means that your registration was received, your payment was received, they got your background check, everything is good, they're sending it to the Board of Nursing. If that says incomplete, you need to call them and find out what they're missing. Something is wrong. As long as that first email you get says application status complete, you are on a good path. If it doesn't, you need to call to find out why. The most common cause of that is your payment got returned. They're not going to process your application if the payment doesn't go through. Now, some banks, I don't know, you know, this fraud thing, I don't know why people commit fraud. It just aggravates me. Because of all the fraud out there, a lot of banks really have tightened up what they will let you spend your money on. And if the bank doesn't recognize this as a valid charge, your bank will block it. You'll think, oh, good, I've applied for the test. And the test is like, we don't have payment. It's not an application. So pay attention to that and make sure you stay on top of it so that your payment gets processed. All right. If you have to contact the Board of Nursing, you will have a Prometric ID. Once you apply, it'll be on that application. Please make sure you make a note of it and be able to give Prometric your Prometric ID. It really helps the process along if they've got to investigate. All right. And then about usually 7 to 10 days after they get your authorization back from the Board of Nursing, you'll get your test date. Homework. You have 2 chapters because it is a weekend. You have chapters 5 and 6. 5 is on dementia. 6 is on skills. We cover skills in class. Read the paragraphs in between. You'll get a wrap-up email today. It'll give you all the links. If you go to our website, FLCNA training, where all of our replays are, test registration instructions is just to the side of class 4. I put it right there, the video, so it's really easy for you to access. Okay, quick and easy. Any questions on what we've gone over today? You have your review sheet. Jacob passed it out to you. All right, look at that. I am 1 minute ahead of schedule today. Woohoo! You guys will have practice time starting next week. Have a fantastic weekend. I'll see you then. For practice time, you're free to practice whatever you'd like. I'm sorry? Oh, thank you. All right, those of you joining us virtually, thank you so much for tuning in. We will see you in class on Monday. We're back Monday at 9 a.m. Until next time, happy caregiving. Bye. Do you need me?